Good morning, everyone. Good evening in Sydney. Welcome everyone to our continued online medical education series. So we are all going through these tough times in this COVID pandemic, and I hope every one of you are safe and doing fine. So because of this COVID pandemic, this has affected us significantly, both in our personal life as well as professional life. However, to keep the academic activities going, because it is going to be at least months, if not years, before we get started with our routine academic activities, we have launched series of online teaching programs in the form of webinars. And an extension of this webinar series is this continued online medical education series. We have a series of modules which are planned on the minimally invasive head and neck surgery. The first module of this series is on transoral laser microsurgery, which we are launching today. And the second part of this event is on the 5th of July, that is the next Sunday between 12 p.m. to 4 p.m. India time. So this meeting has been done in association with HCG Academics, Academy of Head and Neck Oncology of Karnataka, and Chris O'Brien Life House Cancer Center, Sydney. I would like to introduce our international faculty who have been kind enough to take time off and participate in this meeting. My mentors from Australia, Professor Carsten Palm, Professor Farouk Rifat, who will be collaborating with us in this meeting, from whom I have learned all my laser skills. Professor Daniel Novakovic will be joining us tomorrow. From Italy, we have the pioneer laser surgeon, Professor Giorgio Paretti, who will be joining us tomorrow. Professor Cesar Piazza from Milan, Italy, and Dr. Francesco from Genova, Italy. I thank Francesco helping me connecting with Professor Piazza and Professor Peretti and smoothly get this started. This program wouldn't have been possible with the support and encouragement of my senior colleagues, Professor Vishal Rao and Professor Ravi Nair. Again, I would like to acknowledge and thank my mentor, Carsten Palm, for the suggestions in tuning this meeting into a good one. I would also thank my colleagues, Dr. Anand Subhash, Dr. Bhargav, Dr. Shalini Thakur, my fellows, Dr. Joshna, Dr. Apurva, Dr. Yash, and Dr. Abhijit. Also, I would like to thank our association manager, that is CIM Global, Anita, Priya, and team, and academic partners, Journal of Precision Medicine and GHA. So I would also like to introduce about our Academy of Head Neck Oncology of the Karnataka. It's a state association of oncologists, including head and neck surgeons, radiation oncologists, medical oncologists, and reconstructive surgeons. Kindly log into the website www.hnok.org and please register into this. So we've got a lot of benefits to the members. So in terms of education, we have access to certified courses on basic suturing, some understanding about laser surgery, robotic surgery. In terms of research, we have the Nature Online Masterclass course in there. Also, we have internship training opportunities in head and neck centers across Karnataka for young trainees. We have online learning materials in the form of lectures by experts like these, videos, and so on. We got special discounts for trainees in head and neck meets and conferences conducted by HNOK. And also we got to give some financial assistance in the form of loans to procure surgical instruments, as well as to enroll in the Golf IFNOS fellowship course. It's also a great opportunity to collaborate with national and international organizations, as well as an opportunity to get as speakers in the local meetings. With this little brief introduction, I would hand over the screen to Dr. Joshna to introduce the speakers of the day. Over to Joshna.
Thank you, sir. Good afternoon. This is Dr. Joshna. I'm a fellow in head and neck surgical oncology at HCG. So today I'll be introducing all the speakers of the CME. So we have Dr. Ravi Nair, who is our senior ENT and head and neck surgeon and dean of academics at a leading hospital in India. He did his master's in ENT from PG Mer, Chandigarh in 1983, and subsequently he secured a DCCF from Université de Paris, France. He also have received honorable FRCS from Glasgow and a DLO from Royal College of Surgeons, London. Next, we have Dr. Alok Thakur. So he is a professor and HOD at a leading hospital in India. He is also a president of FHNO, otorhinolaryngology and head and neck surgery at All India Institute of Medical Sciences, New Delhi. Dr. Alok Thakur graduated from All India Institute of Medical Sciences and subsequently trained in otorhinolaryngology and head and neck surgery in India and the UK. Next, we have Associate Professor Carsten Palm. So he is the director of head and neck surgery at Chris O'Brien Lifehouse Cancer Center and clinical associate professor in the University of Sydney. Associate Professor Palm holds clinical appointments at Royal Prince Alfred Hospital and Westmead Hospital and has a vast experience in the minimally invasive surgeries of the larynx at Sydney. Next, we have Dr. Vishal Rao, who is presently the Regional Director of Head and Neck Surgical Oncology and Robotic Surgery, and he's also the Associate Dean of Research and Academics at Healthcare Global Cancer Center, Bangalore, India. He is a TEDx speaker and has more than 18 patents filed for his innovations on medical devices, drugs, techniques, and theories. He's also a member of consultative group to Principal Scientific Advisor in Government of India. Next, we have Associate Professor Farooq Rifat. So he is an Associate Professor at clinical appointments at Westmead Hospital, Nepean Hospital, and Chris O'Brien Lifehouse Cancer Center. Next, we have Dr. Akshay Kutpaje. He is a surgical oncologist trained in head and neck cancer management with vast experience. His special interest in minimally invasive surgery of head and neck cancer, especially transoral laser microsurgery of vocal cord, robotic surgery, and reconstructive surgeries of head and neck region. He's playing one of the vital roles in conducting the present CME, that is COMeD. Next, we have Dr. Cesare Piazza. So he was born in Cremona in 1971. He is an associate professor at University of Milan and chief of the Department of Otorhinolaryngology, Maxillofacial and Thyroid Surgery of the National Cancer Institute of Milan at Italy since June 2017. Next, we have Dr. Francesco Misale, who is also born in Brescia in 1989, who is the PhD student of University of Brescia and consultant in the unit of otorhinolaryngology and head and neck surgery of IRCCS Ospedale Policlinico San Martino in Genoa, Italy since May 2020. Finally, we have Professor Prathamesh Pai, who is at present the professor and consultant surgeon and the convener of Head and Neck Disease Management Group, the Department of Head and Neck Surgical Oncology at Tata Memorial Center, Mumbai, India. So with this brief introduction of about all the speakers of our CME, I now hand the connection over to Dr. Anand, who will be moderating the sessions for further presentations. Thank you.
A very good morning to all of us here. So we would start with the opening statements by Professor Ravi Nair, who is the Dean of Academics at HCG Cancer Center.
Hello, am I audible?
Yes, sir.
Yes, you're audible, sir. Can you unmute, sir?
Yeah, I'm unmuted now.
Yes, sir,
Hello.
you are audible now, sir.
Yeah, fine. So, as introductory remarks, I think I'm as excited as any other doctor who has registered for this. I'm looking forward to a feast of knowledge, a sharing of experience in the field of minimally invasive surgery. I want to congratulate our team in HCG Hospital for having put this together. I want to welcome all the speakers from all over the world, and I want to welcome all the delegates who have spent time on this Sunday to join us. Without much further ado, hand it back to Anand and say, please continue with this wonderful educative session.
Thank you, sir. The next to follow would be the keynote lecture by Professor Alok Thakkar. He's the unit head at AIIMS, Delhi. He's a renowned head and neck surgical oncologist and has been a mentor for several surgeons.
Alok Thakkar, sir, can you please unmute?
Muted.
Yes, sir.
Yes, sir, we are able to hear you.
So thank you for this wonderful opportunity. I must say the program's been put forth very intelligently, and congratulations to Akshay and everybody else, Dr. Vishal, everybody who sort of put this together. Pleasure to be here to connect with Dr. Ravi Nair, Dr. Farooq, and all other friends around. Give me a minute. Right. So my job here, of course, is to introduce the topic, and I was a little bit pleased and a little bit, let's say, concerned to see that I have been asked to speak on the evolution of surgical management. It seems I am now looked at as someone who's more relevant to the past than to the present. So I'll take you through to a journey of the past and then take it to how things have developed down to the present with regard to transoral laser microsurgery for early and advanced cancers of the larynx, how we were introduced to it, how things have evolved in our thoughts and in the science, and where things stand today. So in the short time I have, let me first take you to the time I started practice as a consultant in the late 90s. And around that time, when we looked at our results of the last 8-10 years, this is what we had. In terms of survival, we weren't doing badly even before we had laser and before we had chemoradiation. We weren't doing badly. And if you look at what we had in terms of T1 and T2 or stage 1 and stage 2 results at 2 years, we weren't doing quite so badly. Of course, when it came to early cancer larynx, we were looking at cure and preservation of function. That's given. And surgical assessment in those days used to be entirely on clinical basis. We weren't quite using it as much as we use now. And treatment options basically included radiotherapy. I would say 98% of the patients were having radiotherapy. We did have the laser available to us from the 90s, but it wasn't used very effectively, and the odd partial laryngectomy. As things developed, what the laser did to us was basically improve functional results of surgical treatment. And as we moved from open partial laryngectomy to endoscopic partial laryngectomy, endoscopic cordectomies, we got advantages which were, of course, with hemostasis, and hemostasis allowed you more precision, more magnification of the microscope. And here you were able to do low morbid resections without a tracheostomy, because certainly if they were doing partial laryngectomy, there was also the tracheostomy. But it really wasn't the early cancer. It wasn't really the early cancer which which excited us. It was the potential in advanced cancers which excited us, because at that moment in time, we hadn't quite moved on to chemoradiation yet, and advanced cancers of the larynx were a huge, difficult area to get involved with. Preservation of function was a problem. TEP had become available. Near total laryngectomy was used now and then when appropriate, and radiotherapy with surgical salvage was one option for organ preservation, and total laryngectomy with neck dissection with post-op radiation was the other option. Again, it was pretty obvious even then that patients who had surgery followed by radiation did much better than radiation alone. And even in the T3 situation, this is all data from the 2000, which I have fished out. Even in the T3 N0 situation, wherein you would expect that that radiation would have done reasonably well, we weren't doing all that well. And the reason for that obviously was that because we weren't doing radiology, there were a fair number of T3s which actually had cartilage involvement and which we were not quite classifying as T4s at that moment. So the potential for laser for advanced cancer larynx as an area wherein you could do organ preservation, surgical organ preservation with of course reasonable cure rates was taken as immense. So this is data which came in from Germany for glottis and then for supraglottis, which were exceedingly exciting in terms of offering organ preservation with reasonable cure rates. This was before chemoradiation, and as you start to see, the data that they presented was all with regard to pathological stages, which was because it was usual in those days to not have high quality pre-op CT scanning available, and it was often the case that the disease was overstaged when you did the operation. That is not quite the situation today. So we moved on from situations of en-bloc resection for small tumors to sectioned excision for larger tumors. There was a great amount of controversy with regard to that, which generally got resolved as data came in to tell us that sectioned excisions were not compromising cure rates. We developed the concept of compartmental resection, rather the type 4 cordectomy, wherein you would remove the periosteum from the inner surface of the thyroid cartilage and get a compartmental resection, which would allow a full cordectomy till the cartilage, and was taken to be oncologically as sound as a partial laryngectomy done from outside with as good functional results. But of course, this wasn't the only area where change was coming. Change was coming in many areas. And I introduce you to this slide, which is a favorite of mine, which tells you how things have improved over the times, or what are the major issues that have had an impact on the treatment of medicine, but primarily in the treatment of cancer larynx. So CT scans have been around for a fair length of time, but good quality CT scans or high definition CT scan wasn't quite available till the late 90s or the early 2000s. The laser's been available for a fair length of time, and partial laryngectomy has been available for a fair length of time. But again, it took a while because these are techniques which are fairly intensive or difficult in terms of learning techniques, which took a while for them to actually get accepted and be widely used. And all of this was available by the 2000s. And more than that, it was chemotherapy which made a huge difference to how things were being done. So post 2000s, of course, the role of transoral laser microsurgery, or the enthusiasm that we had with transoral laser microsurgery, slowly waned for advanced lesions. This was data which came in from Barcelona, which told us that for T3 lesions, you subclassify T3 lesions, and patients who have pre-epiglottic phase involvement, the endoscopic technique is a great way of doing things. But for vocal fold fixation, laryngectomy-free survival wasn't doing very well, which is why we no longer quite get involved with this kind of situation with T3 vocal cord fixated larynxes with the laser, but prefer chemoradiation in that situation. And again, for focal cartilage invasion, a laser wasn't doing quite as well. There was an exceptionally good paper and good experience which came in from the Mayo Clinic from Dr. Haney, which looked at advanced lesions and replicated the experience from Germany and from Europe, and sort of convinced us that this is something that could be done outside of Europe too, with fair number of T4 patients and T3 patients. Of course, selected patients, but nevertheless, exceptionally good results in terms of survival overall and disease-free survival. Good results in terms of laryngeal preservation at 2 years and 5 years. Good years in terms of laryngectomy-free survival. Some issues with peri-op morbidity and mortality, which was getting to be the norm now with chemoradiation. And they actually compared the results with the RTOG 9111 and actually went on to say that at least for this small data set of 120 odd patients, disease-free survival and laryngectomy-free survival outscored the results that you could get with chemoradiation. That was interesting. They also were very good with their functional results, and in terms of swallow score, they are excellent swallow function with normal function, with episodic or daily symptoms, with normal function, fairly normal function in terms of swallow, and not so good functions in terms of voice. So what has happened over the years is that as we have moved on to as a society to expecting better voice outcomes, and as society has moved on to getting more involved in electronic communication like we're doing now, voice does become a very essentially important function that patients value and we value. They told us that in terms of functional larynx, they could only achieve a functional larynx in 40%. What they meant was that patients were swallowing well because there were hardly any patients who were feeding tube dependent, but patients were often not speaking well because the communication status for these patients was often in the range of median communication score of 2, which basically means grossly dysphonic. So the problem with getting involved with the lasers for very, very extensive lesions or very extensive type 4 cordectomies, type 5A cordectomies is of course the dysphonia. And that again is our experience. So when we get involved with larger lesions, we can get good oncology, we can get good swallow. As you can see, this patient is having no issues at all with swallowing or any saliva trickling down the larynx, which is primarily so because the larynx is architecturally positioned in exactly the same place. The pharyngeal muscles have not been disrupted because you've done the operation from inside. The sensation has not been disrupted because you've done the operation from inside. And the coordinated swallow is fully preserved. But the problem, of course, is the speech. I don't know if you can hear this, but if you can, he's terribly dysphonic, very breathy, very dysphonic. And you can expect these patients to improve as the scar sets in, but nevertheless, voice is a major concern. And invariably, these patients are going to come back to you a year or two after they have been disease-free and express a desire to get their voice improved. So from this evolved the situation wherein the current leaders in this issue, which is of course from Europe, Dr. Peretti's group and everybody associated, came out with this article, which I think is a very relevant article. It's not quite evidence-based, but opinion-based. But nevertheless, it lists out the situations wherein perhaps it's not so good to get involved with the laser. Not because you can't get good oncology. Sometimes there is compromise with oncology, and sometimes there's compromise with functional results. So these are situations with inadequate exposure. Of course, there's a scale for it now, and you will hear about it as the day progresses. Anterior commission involvement can be a problem, but having said that, it's not that it's an absolute contraindication. We do get involved with anterior commissures. Invasion of the posterior paraglottic space can be a problem oncologically, and erythenoid fixation can be a problem oncologically. This was something that was practiced quite widely in the 90s, but as I showed you the Barcelona paper from Vilasia, which sort of tells you that in the situation where erythenoid fixation, you can expect a laryngectomy-free survival in only 40%. Massive infiltration of the pre-epiglottic space, again, is a contraindication. Minor problem is not a problem. And minor thyroid cartilage erosion is something which was practiced quite a bit in the early days of the laser, but no longer favored, because if you can detect it pre-op by the CT, then there are certainly better ways of getting involved. So with this, you open up the space for the open partial laryngectomy, and these really are the situations wherein open partial laryngectomy with all the vertical, partial, horizontal, and supracricoid laryngectomies can get involved. These are a little bit compromised in terms of functionality when you do these operations compared to the laser or compared to TORS or TAUs. These are a little bit compromised in terms of swallowing outcomes, but oncologically, they can actually give you advantages. And the same cautions for transoral laser microsurgery actually are in many ways the indications for open partial laryngectomy. So inadequate exposure, of course, becomes an indication for open partial laryngectomy in situations with mobile cords. Anterior commission involvement, again, very well handled. Thyroid cartilage involvement, thyroid cartilage invasion, very well handled by the vertical partial laryngectomy. Invasion of posterior paraglottic space, I think, continues to be a concern. There's some data which is very encouraging, but for most of us, we don't quite involved with posterior paraglottic space or required fixation. Massive infiltration of pre-epiglottic space, well, there are limits, but you can do a partial laryngectomy. Certainly a horizontal partial would cover the pre-epiglottic space very well. And minor thyroid cartilage erosion is also oncologically covered very well by the open partial laryngectomy. So this has sort of set out, or you could say evolved the situation as to how you differentiate as to when to get involved with the laser and when to get involved with an open partial laryngectomy. So today, how do we look at T1 and T2 situations, early cancer larynx? In terms of evaluation, stroboscopy to my mind has been a disappointment. We don't quite use it very much. It can be of some use in differentiating benign from malignant, but not very useful. NBI, which came in recently, is a very useful way of assessing the lateral spread of superficial disease or the lateral spread of epithelial disease, and narrowband imaging does open up a little bit extra. So if you look at this, I'll just go back. We find this useful to stage. The moment narrowband imaging comes in, you can see a little bit more that the disease is extending and the leukoplaque is extending a little bit more anteriorly, and it helps you stage a disease and minimize the positive margin rate at surgery. This, to my mind, has been a big advance. And this is data which comes in again from Dr. Peretti's group, which tells you that the rate of positive superficial margins, not date margins, was significantly decreased by using narrowband imaging than in the control group without narrowband imaging. So this is certainly something which, to my mind, has made a difference and a significant advance when you apply transoral laser microsurgery to early clotic lesions. But going on from there, the advantages that you get from CO2 laser haven't quite manifested in terms of advantages in terms of cure rates or functional improvements compared to what you were getting with radiation therapy. And this debate continues to rage as to what is better, radiation therapy or transoral microsurgery. And oftentimes, the metrics which get analyzed are not cure rates. Quality of life is being analyzed for a fair length of time, still is analyzed. And now you're often looking at patient convenience, length of hospital stay, cost issues before you start to take a call on which is better and which is not. But having said that, I think it's fair to say that both are acceptable and both are very good treatments for T1 situations of cancer larynx, excepting for the odd situation wherein exposure may be a problem, but both are very good situations. Points have been made for and against, but none of them are dramatically convincing for one to overweigh on one treatment modality over the other. Coming on to the T2s and the early T3s. By the early T3s, I mean the radiological T3s, the minimal pre-epiglottic space involvement, the minimal paraglottic space involvement, which you don't quite see on clinical evaluation, or the T1s with the extension into the supraglottis, the glottic lesion going to supraglottis, that kind of situation. Again, there is no clear data to tell us what is better. Certainly with the laser, given the appropriate technology, the appropriate patient, and the appropriate clinical expertise, there is little that is not possible, and all has been done and can be done, so to say. You can be assured of a aspiration-free swallow following a laser resection, almost certainly assured in a T1, T2 lesion. With voicing, there's a bit of a problem, but when T1, T2 lesion, you do have the option of using things, even if you've taken away the true cord, you can get supraglottic structures to vibrate, as you see in these videos, and you can go in for supraglottic voicing options. And oftentimes, the supraglottic voicing options, you can get reasonable voice outcomes. So good to do can be done in terms of what is better between surgery and radiation. No clear data. There's probably the largest systemic review which came out a couple of years ago, which told us that in terms of local control at 5 years, there were similar results in terms of 76% for radiation and 77% for transoral laser surgery. So really nothing to choose from. But if you look at the data carefully, there is a suggestion that in terms of overall laryngeal preservation rate, maybe lasers are doing a little bit better. I cannot voice in that area again. But there is this space for open partial laryngectomy which comes through, and open partial laryngectomy is something which is to be strongly considered for T2 lesions. But the same indication we set out previously, as we said, lesions getting close to the thyroid cartilage, abutting the thyroid cartilage. So inadequate exposure, maybe anterior commission involvement. We are not quite sure about thyroid cartilage involvement associated. Maybe infiltration of the pre-epiglottic space and minor thyroid cartilage erosion certainly would be indications for getting involved with a partial laryngectomy for T2 situations. Also, in our practice, salvage. So if you're looking at a T2 which you're salvaging or a T1 that you're salvaging, we haven't quite had joy with the laser, and there is a meta-analysis out to show that there's a 20% difference in terms of long-term survival that you can get with a salvage partial laryngectomy versus a partial transoral laser resection. So again, we would prefer a partial laryngectomy in that situation. So in terms of surgical treatments for T1 and T2 early cancer larynges and maybe the odd T3 cancer larynx with a mobile vocal fold, these are both options, the laser and the open partial laryngectomy. And I hope I've been able to convey as to how you choose between which one to use when. So thank you.
Thank you, sir. Thank you for giving a compendium of where we have been and how we have evolved over the last decade. Last 5 decades. Thank you, sir. Next, I would like to invite Professor Carsten Palm from O'Brien Lifehouse to give his talk. The talk would be on the principles and safety of transoral laser microsurgery of the upper aerodigestive tract. We would be taking the questions after the talk. So key questions would be taken up. So any participants can post their questions in the chat box, which would be answered at the end of the talk.
All right, can you hear me?
Yes.
Yes, sir.
You can hear me?
Yeah.
Okay, so I'm just about to share my screen. Can you guys see my screen?
Yes.
Yes.
Great. So, look, thank you very much to everybody for coming along to this meeting. I think this is a great initiative, and everybody should really be congratulated for this. My talk is going to be a little bit different, and the pace is going to be somewhat slower, and please bear with me. My talk is really going to be on the principles of laser surgery and a little bit on safety aspects when we are performing this procedure. I come from Chris O'Brien Lifehouse. I have no disclosures. One of the big problems with laser surgery is that to the general public, people don't really know exactly what we mean. There's always some mysticism surrounding a laser, and people think that there are some magical properties. And you can see this is a famous scene from Goldfinger where James Bond is just about to be cut through by a laser. And that's the kind of sort of image that that lasers have in the general population. But we need to understand that laser is an acronym, and it stands for the light amplification by the stimulated emission of radiation, which is quite a mouthful. And in order to understand this, we've actually got to understand a little bit of Einstein's theory of quantum physics. And we've got to understand that we have the nucleus and electrons flying around the nucleus in different energy states. The ones closer to the nucleus are at a lower state than further apart. And what happens is when an electron gives off a bundle of energy called a photon, as you can
sorry to
see over
disturb.
here, and it's spontaneous. That's what happens when with lots of different wavelengths, what we see with normal light. And that's kind of spontaneous emission. And what happens is an electron from a higher energy state drops down closer to the nucleus, and it gives on a photon of light. Now, the thing that you can do is you can actually impart energy to this state and excite this atom. And what can happen is that a photon that you've introduced can collide with an electron, which then falls to a lower energy state and thereby gives off two photons of
Professor Palm?
Can you hear me, guys? Or
yeah, so your presentation is not coming, it's not changing.
Sorry? Can you hear me?
Yeah, your presentation is not coming on. So if you could just restart your presentation and
sorry. Can you see it now?
The presentation mode. The slides are not changing.
Can you just stop your screen sharing and
so
restart
it's still
it?
So can you see my slides?
Yeah.
No.
Can you put it in the presentation mode?
Hang on. I'll share again. I've just stopped sharing and I'll reshare. Share. Sorry, guys.
Yeah,
can you see it now?
Yes, yes.
Yeah.
Can you see my slides now?
Yes.
Can you?
Yeah, we can.
Okay, great. Can you see the slide moving forward?
Yes.
Yeah. Yes, we can.
Great. Do you want me to start from the beginning?
Yeah, that would be great.
Preferably, yes.
Sorry about that, guys. So my talk is going to be a little bit different to the one we've just heard. I'm really going to slow down the pace a little bit and get back to basic principles of laser physics and a little bit on the safety aspects associated with using laser surgery for upper air digestive tract cancers. I come from Chris O'Brien Lifehouse and I don't have any disclosures. Whenever we talk about lasers, there is a certain amount of mysticism and magic associated with it. And what we really got to understand is that laser is based on very sound principles of wave physics. And we need to understand that laser is actually an acronym that stands for light amplification by the simulated emission of radiation. And that's quite a mouthful. But in order to understand what a laser is, we need to actually understand a little bit about it from Einstein's quantum theory of radiation. We've got to understand that in the nucleus, there are certain energy states in which electrons find themselves, and usually there are higher energy states further away and lower closer to the nucleus. Now, each electron carries some energy, and when an electron drops from a higher energy state to a lower energy state, a photon of light is given off. And that's what we call spontaneous emission. But we can actually stimulate that by imparting energy and allow photons to collide with an electron in a higher energy state, which then drops lower. And what actually ends up happening is that both the incident and emitted photon are in phase. And this is basically the concept of the intense light that makes up the laser. And the characteristics of a laser are these. It's monochromatic, means it's got one wavelength. Like over here, we've got the CO2 laser. Further down here, we've got the KTP. So it's one wavelength. It's very intense light. It's collimated, which means it's made parallel. And importantly, it arrives at the same time and space, and it's in phase. And so what ends up happening is we have a laser which has a medium which is either made up of CO2 or KTP. We have those particles whizzing around. We impart some energy to the laser, and then the light comes out through a little slit within the laser, and then we use a lens to focus that laser. Sorry guys, can you all hear me or?
We can hear you.
Great. So this is kind of the basic concept of a laser, and we all know from the physics of light that there are 4 things that happen when that laser light hits another medium. There can be reflection of the light. Oops, sorry. There can be reflection of the light. There can be scatter. There can be partial transmission. And there is a certain degree of absorption of the light or the energy of light within the tissue. And it's this absorption which causes the effect, and that's the effect that we use in terms of cutting for our laser surgery. And there are a number of reactions. There is heat and sound, and there can be photochemical reactions. And depending on the wavelength of the laser, the characteristics of the tissue that we are lasering in, certain aspects of the beam in terms of the power density, the size, uniformity, the exposure time, and the pulse characteristics, there are certain characteristic effects. And you can see here the carbon dioxide laser, it actually has very minimal penetrance in skin, whereas other lasers such as the ND-YAG have quite a number of millimeters that it penetrates the tissue. So you've got to be very careful with these type of lasers because they can cause injury way beyond where you're actually intending to make the cut. And this is again a real quality that we use within the CO2 laser, which makes it a very safe tool to use. The actual characteristics that we use and that we can change certainly the power. So when we have a laser machine, you know, we can set the power of the laser, which is measured in watts. We can change the focal length and the spot size, and that's actually a really critical aspect of getting a nice clean cut when we're using the CO2 laser. And for example, when we're using a laser through a micromanipulator coupled to a microscope, you know, the focal length that we like to work with is about 410 millimeters. And you really want to have a spot size that's absolutely crisp. And usually with good lasers, we're looking at about a 1/4 millimeter. Power density is important of how much watt goes to the area. So that goes back to the smaller size you have, the higher power density. There's the concept of fluence, which basically relates to how long you're actually lasering in one spot. And then depending on your mode, whether it's a continuous mode where you turn the laser off, it is on all the time until you turn it off, or you can put it in pulse modes where there's lots of little pulses. It has different cutting characteristics. So it's really the spot size that we can change, the power, the mode, and the time that we are lasering. And just a little bit more on continuous and pulse mode. Certainly in the upper air digestive tract, we used to like to use the laser in a pulse mode, which means we have a very small area of intense laser energy and then a period of nothing, which allows the tissue to cool. So what ends up happening is you get much more efficient and clean cutting without carbonization. And you can see that here in the orange, with the black being the carbon on a continuous mode, and with the super pulse mode, you're getting the cutting with limited charring. And this is kind of demonstrated here graphically. You know, the energy, the temperature goes up, but then there's enough cooling and it just keeps going. And as long as you space the pulses enough for the cooling to occur, you don't get this continuous increase with each pulse. So this is really a fantastic technique, which allows cutting very delicate tissues and reduces particularly the collateral damage to the unaffected tissue adjacent to where you're operating. The thing you have to realize, it doesn't coagulate, because every time it turns off, you stop the energy and you don't quite seal the vessel. So it's not a great technique for causing coagulation. So when you look at the laser energy, it's basically heat transference to the tissue, and you can really see what happens. You've got the energy which gets absorbed, and then you have heat, and generally you cut the tissue by vaporization. You basically get boiling and an almost explosion of the tissue, and the heat actually gets carried away by the steam and the plume. If you continue lasering in one spot, you end up getting conduction, but the conduction can sort of stop at a certain point, and it keeps leading to carbonization, which makes it quite inefficient. So this is the concept. When you are cutting, you want to cut with a reduced, with a smooth motion, not staying in one spot all the time, and that's when you reduce the collateral tissue damage. We did a study some years ago where we looked at, the laser margin, and we worked out that about 1/3 of a millimeter of the laser margin is denatured, and you can't comment on that margin during pathology. So this is important in terms of getting the margin right, but also shows that the collateral heat injury is quite minimal with the CO2 laser, and you hope that the healing and functionality is improved when you compare it to other energy sources, such as simple electrocoagulation. So the CO2 laser, which is in the invisible spectrum, the key thing is the red laser that we see is actually not the CO2, but it's the helium aiming beam that's coaxial. It's a very safe laser because it has a very high absorption within water within a fraction of a millimeter. So you're not going to get that kind of transmitted beam and increased collateral damage. There is very minimal scatter and reflection and transmission. One of the downsides is it can only be used effectively within rigid delivery systems, except there are some fiber systems that have been developed, but it's generally, you need a rigid system. So this is really just a bit about the laser physics, and the next part of the talk is really about the training and safety aspects of laser surgery. I think in order to be a successful laser surgeon, you need a number of factors, and you need to have a number of experiences. I think we as ear, nose and throat, head, neck surgeons are best placed with our endoscopic skills. I think it is vital that if you're going to laser cancers, that you've done a stock standard head and neck oncology fellowship to understand the concept of oncologic resection and working in with multidisciplinary teams. I think there's no doubt that everybody has to have expert training, and I had a great pleasure back in 2003 to spend some time with Professor Steiner. I think everybody needs to be a laser safety officer and undergo the laser safety officer course. And I think the best results are really achieved when you're working within an endoscopic laser service, which has a number of factors, and we'll go into that in a little while. Lasers, although very effective in cutting and excellent in treating upper air digestive tract cancers, can be associated with a number of terrible accidents. Fortunately, these are quite low, but can be quite devastating. And the most common are really eye and skin injuries, of which the eye is clearly the most significant, because you've got to imagine that if the laser hits your lens, it basically focuses the beam on your macula and your retina and basically leaves you blind. One of the more devastating effects is airway fires, and we'll talk about this in a subsequent slide. I think the reason why things happen is because staff are careless. Incidents happen because there is lack of compliance and safety precautions, particularly not wearing the appropriate eyewear. I think clutter in the operating theatre and excessive theatre personnel that is not immediately relevant to the case also really causes problems. I think you've got to be trained and prepared to deal with issues. Fortunately, accidents are rare, but you've got to understand that they can be quite disastrous. So one of the worst things that happens, and the things that we always get worried about, is a laser fire. to understand why fires happen, you really got to understand this triangle. You got to clearly have a heat source, of which is the laser. You've got to have a fuel, but the driver is oxygen, right? So oxygen is absolutely important. So here's just a little video that shows you what happens when you're burning a little ET tube with a normal candle. This is in air, you get a bit of smoldering, but watch what happens when you add oxygen. It's like a jet, right? And this is 100% oxygen that's being blown down there. And this is the problem with the heat going down into the distal airways. So one of the absolute critical things is when you're lasering is the FiO2 that's being used should be as low as possible. And my practice is usually to use an FiO2 of air, 20-odd%. And it's really important that you work closely with your anaesthetist to make sure you have a regular anaesthetist to avoid this devastating complication. This is a case of a chap who had exactly this, an airway fire. And here you can see what's happened to the trachea after this jet of fire went down into the distal airways. And here you can see the complete denudation of the mucosa. The cuff actually exploded. So this is a laser safety tube. It's really not preventative. Again, I think oxygen is the key. Here's the circumferential burn. Fortunately, this patient did not have any issues in the distal airways because most of these people succumb to an impaired alveolar ventilation. And so really the management, if you ever have this kind of devastating problem, the first thing you have to do is disconnect the circuit in order to turn the oxygen off. This is the most critical thing. You should douse the fire with water. You should remove the tube and importantly perform rigid endoscopy and perform the airway. But the best thing is to prevent it. And importantly, you need to have the laser safety officer or their representative in theatre at all times. You need to have a proper protocol, which we started when which we set down when I started back in 2003. You need to work out the sort of a diagram of where everybody and where the equipment is positioned in the operating theatre. As I said, it's really important to have minimum staff and reduce the clutter. Clearly, you've got to protect the patient and your staff, and you've got to check your equipment and make sure it's up to date and store it safely. So the real challenge is setting up an endoscopic laser service in a well-established head and neck unit. And the key thing is to work within an endoscopic laser service. You need to have the oncologist, you need to have the proper training, you need to have the multidisciplinary team approach, and importantly, the institutional and infrastructure support. You've got to practice safe environment and audit, research and education, and you've got to work with other medical specialists, importantly, your anaesthetist, your pathologist and your other oncologist, and also your allied health staff, such as your speech and language pathologist, in order to get the best outcomes. So this was just a quick little talk about some of the basics, and I thank you very much for your attention, and sorry about the problem at the beginning.
Thank you, Professor Palm, for a nice talk to begin with the basics. So we have a couple of questions. So you talked as the continuous mode and the other one the pulse mode. There's a third mode called super pulse. Can you just elaborate on that as well?
Yeah, look, it's just my understanding, the super pulse mode is just a higher frequency of pulses, so that it's a shorter pulse width, but lots more, and therefore it just basically burns like, it cuts basically in a continuous fashion, and really reduces the charring. So it's just a different setting within the pulse mode.
Right. Another question. So surgical safety checklists have been important thing to reduce, misadventures during surgeries. Any tools for laser or endoscopic units for surgical safety checklists before we begin?
Yeah, I mean, there are huge protocols in place when you are doing laser surgery, and I think the absolute key is for your staff wherever you're going to practice laser surgery, your staff to all undergo laser safety officer training, which is we run in Australia, which is run by a number of people around the world to credential people. You've got to have a laser safety officer with your institution. You've got to record all your cases. You need to have laser nurses who run your lasers when you're actually performing the surgery. I think it needs to be that the laser machine needs to be run by an independent person to the surgical team. You need to record your data. And I think you need to be highly vigilant whenever you're performing this procedure. So absolutely, there are massive protocols in place, and we have, our volumes of laser safety are many pages. But I think the key thing is that each institution needs to run laser safety officer courses for all the staff involved, and everybody needs to be credentialed.
There's another question. So the use of low-level laser therapy, which is more often used for musculoskeletal pains and other, does it have any role in early lesions of vocal cord? So the low-level laser therapy, which is about 100 to the lower, wattage and power setting.
Right. So my training has been mainly with the CO2 laser, because the CO2 laser, the treatment of cancer still adheres to the Halstedian principle of getting a complete surgical resection. That's the key. The KTP laser clearly has gained some increased interest, and its role really is to ablate the vessels that feed the cancer and thereby starves the cancer. One of my real concerns about this, I think it is a great modality for pre-malignant or lesions and dysplasias, but for invasive cancer, I guess as a trained oncologist, I always like to have a specimen that needs to be analyzed by our pathologist and ensure that the margins resected are clear.
Also on airway fires that do occur with laser surgeries. So have you faced any, and what are the immediate precautions that you take the moment it occurs?
So touch wood, I've never had an airway fire. The pictures I showed was a colleague at another institution who kindly shared this. Clearly, this is a devastating complication. It is a potential career-ending complication, and certainly a patient-ending complication. And I think there are some very simple things that you can do to prevent this. I think, as I said, everybody needs to have done a laser safety officer course. I think there needs to be good attention in the operating theatre and a regular team that performs this. There needs to be very close communication with both the anaesthetist and the surgeon. And I think one of the most significant ingredients in causing a fire that causes significant injury is oxygen. So my personal belief is if you're performing surgery with very low FiO2, you will not have the sort of devastating jet that you saw in the video when you added oxygen.
Right. Thank you for the talk. I think we don't have any further questions, so we move on to the next talk. Thank you.
Thanks.
So the next, we look at how the basic assessment in transoral lasers, the microsurgery, how we examine what is the history, what are the investigations that would be relevant. So Dr. Francisco Misale from Italy would be giving the talk.
Hello, everybody, and thank you for this kind invitation. I think that now you should see my screen.
Yeah, so your screen is up.
Okay. I just have to, sorry. I still have to remove the bar that is hiding some part of the slide on the right side of the corner. Okay, I think that anyway you are not seeing it. Okay, hello everybody. I'm Francesco Missale from the University of Genoa, from the clinic directed by the Professor Peretti, where I trained when I did my residency training, and nowadays I'm attending a PhD program at the University of Brescia, and I'm a young consultant in Genova. Just a brief introduction with this timeline on some several relevant papers about the history of laser microsurgery for the treatment of laryngeal cancer. Of course, you can see that everything started in 1972 with the adaptation in between the operating microscope and the micromanipulator of CO2 laser. And during subsequent years, there has been an increasing of the experience in some relevant centers, such as the one directed by Professor Steiner, and with his huge experience with also the papers with the Canis, they try to use the laser in all the T stages of laryngeal cancer. And again, to remember that when we have new techniques, there is a time for a description, detailed description of classification of these techniques that let us to compare the results in between different centers. So it's relevant to remember the European Laryngological Society classification for chordectomies and its modification. There are two more relevant papers, one regarding the type 6 chordectomy and another regarding supraglottic resections. And at the end, there is also time for a critical revision of the results and thinking about limitation of this kind of technique. And just to remember, this paper previously showed. Of course, to achieve good outcomes facing with this kind of technique is relevant to consider several issues regarding the patient, regarding the multidisciplinary group. Of course, we need to do a careful patient selection to apply an accurate diagnostic workup, sometimes including imaging, working in a multidisciplinary team. So remember all the other techniques, treatment techniques that are available and should be considered in each cases. Of course, to achieve a good laser surgery on the larynx, we need to have an adequate exposure of the field. And furthermore, to apply also intraoperative diagnostic workup, and after that, to follow an adequate postoperative follow-up. Which are the crucial issues to be faced at the moment of the diagnostic workup? Of course, the supposed histology of a lesion, its superficial spreading, its possible deep and submucosal infiltration, the possibility of multifocality or synchronous lesion, because we have to remember that most of these cases are related to habits like smoke and alcohol consumption, and so there is the canceration, the field of cancerization of the mucosal upper airways, and so during our diagnostic procedures, pre-treatment procedure, we need to assess if other lesions are present, and lastly, a correct assessment and definition of vocal fold and arytenoid mobility. And to do so, some crucial steps are a flexible panendoscopy, including also videolaryngoscope and biologic endoscopy techniques that during the last decades showed their usefulness in this specific setting for the evaluation of upper airways. Second, in selected cases, also imaging techniques are mandatory. And lastly, once we choose a transoral laser microsurgery, before starting the surgical procedure itself, some intraoperative endoscopy with rigid telescopes and in selected cases other assessment tool like the hydrodissection could be useful to better define the treatment. Talking about flexible palendoscopy, just to remember the usefulness of laryngostroboscopy, that has some advantages but also some limits, because there are papers that showed his high sensitivity for detection of cancer, but poor specificity, also because difficult can differentiate premalignant lesions and grade them preparatively. But of course, it's an useful tool to be integrated with the other biologic endoscopy tools, because let us to predict the deep extension of a potential squamous cell carcinoma. So it's invasion into the vocal ligament, and so in this way, if we don't see any mucosal wave, we must think that at least a subligamental or a transmuscular cordectomy should be done. The other useful tool is to include during the flexible panendoscopy workup biologic endoscopy tools such as narrowband imaging. That is one of nowadays available tools, and its characteristic is that apply a filter at the moment of derogation of the light, and so it's a pre-processing filter and not a post-processing one, selecting two wavelengths, the 410 and the 540 that have the highest affinity to hemoglobin, and so the aim is to increase and to enhance the vascularity of the tissue, and let us see better if there are critical features and specifically vertical vascular abnormalities, such as intrapapillary capillary loops that are described to be associated with premalignant or malignant transformation. Here are some clinical pictures. On the left, you can see vocal cord leukoplakias involving both vocal cords, and applying the narrowband imaging, we don't see any atypical vascularity inside or around the lesions, and the final pathologic result was keratosis. And the second picture at the anterior side of this left vocal cord erythroleukoplakia, we can see some dot spots suggesting us some at least premalignant transformation. The final pathologic diagnosis was squamous intraepithelial neoplasia, mild grade. Whereas in these cases, you can see better aberrant vessels with intrapapillary capillary loops that are suggesting, again, at least a premalignant transformation, but aberrant vessels more suggesting in situ carcinoma or squamous cell carcinoma. The accuracy of narrowband imaging compared to white light have been proved to increase the application of narrowband imaging showed the improvement of the accuracy of the panendoscopy, and in the laryngeal site was described a 21% increasing of such accuracy for detection of squamous cell carcinoma. And reviewing the literature, again, the sensitivity of these techniques is quite high, and also with adequate specificity. It's important to remember this classification, that is a dichotomic classification regarding the vascular changes that can be observed into laryngeal lesions. It's relevant because its dichotomicity let us to obtain good inter-rater agreement about judgment, and it's simple to be applied compared to other classification like the so famous NEED classification. And just the application of the detection of vertical vascular changing compared to horizontal vascular changing that are more typical for pre-malignant or malignant lesions. So when we apply the narrowband imaging, we have to search in the tissue this kind of abnormalities that are a suggestion of at least a pre-malignant transformation. Some other examples of pre-treatment endoscopies. Here you can see a leukoplakia without any vascular abnormalities inside of it or also at the boundaries. The laryngeal stroboscopy showed a presence of the mucosal wave, and the final diagnosis was consistent with keratosis without atypia. In these other cases, it's a erythroleukoplakia of the right vocal cord. You can see that enhancing the vascularity with narrowband imaging is clearer the extension of the lesion. Again, the laryngeal stroboscopy was good, but the final diagnosis was a carcinoma in situ. And this underlined the relevance of the biological endoscopy together with the laryngeal stroboscopy. Of course, there was not an invasion of the vocal ligament, and so this is the reason for the normal laryngeal stroboscopy, but the biologic endoscopy suggested us at least some pre-malignant transformation before going to the surgery. And so in these cases, for example, a subligamental cordectomy was chosen for this reason. Talking about the second point, so in which case do we need also to assess with cross-sectional images like CT scan the case? One of the reasons is when we see a lesion involving the whole ventricle, and so we have some suspicion that there is a involvement of deep places, such as the anterior paraglottis spaces. A second reason is when we see an impairment of the mobility of the vocal cord, like in this case, and again, there was an involvement of the anterior paraglottis spaces. So in every situation in which our endoscopy can suggest as something more than a T1A or a superficial T2 glottic lesion, it's better to perform a cross-sectional images. And the CT scan for the larynx is nowadays still the gold standard, but in selected centers, also MRE can provide nice and good information about differentiation and about the anatomic of the soft tissues. The third reason to perform a CT scan is the involvement, transcommissural involvement, and so we have to rule out the extension through the thyroid cartilage. In the weakness zone, there is just upper or just beneath the anterior commissure. And to remember this new imaging checklist provided by the European Laryngological Society, that is interesting because it's a way to provide fully detailed descriptions of each cases, just following a checklist. And I recommend you to read the paper and also for a self-evaluation of the DICOM files provided by radiologists. Let you to, there is a quite a guideline, for example, how to put the axial plane in the proper position, because it must be parallel to the glottic plane. And this is the first step to be done before starting looking at cross-sectional images. And then once we have done a preoperative full complete workup, there are some tools that can be done also in the OR before starting to do the surgery. And the first one is to properly assess the extension of the lesion through rigid angled telescopes that let us to see the detailed extension, the involvement of the ventricle, and the possible involvement of the roof of the ventricle that change the stage of the disease. Secondly, again, applying also in this situation, biologic endoscopy tools that, just to remember, means that pushing a button and the filter will be turned on. And thirdly, in selected cases, the hydrodissection into the Ranke space with the saline solution can be useful to help us the choice of the treatment in terms of subepithelial or subligamental chordectomy. And so talking about, intraoperative endoscopy, we need to assess as best the extension of the lesion in terms of superficial spreading to plan the resection cuts. And then, so studying the full ventricle, the anterior commissure, and the subglottic extension that not always are possible during the preoperative office-based workup. Here, just some cases to show. This is the preoperative endoscopy. And you can see a lesion extending on the right vocal cord and the anterior third of the left vocal cord. With the narrow bed imaging tool, you can see a lot of intrapapillary capillary loops. This is the intraoperative workup with the rigid endoscopes. With an angle endoscope, you can see better the inferior extension of the lesion. And in this case, yes, also the ventricle, that was, the roof was free. A second case, and here just a suggestion, avoid bleeding. And this must be known also by the anesthesiologist. During the intubation, that must be done carefully. In this case, there is, yes, some bleeding that disturb our evaluation, but not too much. In other cases, when we have more bleeding, there is the full absorption of the light, and so you cannot evaluate well the lesion, and you cannot detect the atypical vascular abnormalities that you need to search during this phase. And the third case, again, a lesion of the right vocal cord, but with the help of nerve beam imaging again, you can better see also on the left vocal cord some abnormalities that were not so clear with just white light. And soon you'll see also with the angled and 120 telescope the better assessment of the anterior commissure. Here, these are all abnormalities, orthogonal abnormalities that are suspected. Again, in this region, and these are aberrant vessel. Okay, so also here at the level anterior commissure is the view from the subglottis. This is a continuity, so T1B. And third, in selected cases, when you have, for example, an erythroleucoplakia that is not so suspicious, applying the diagnostic workup, so you are doubtful if it's a keratosis or a dysplasia, you can do this maneuver with a needle, inject saline solution into the Ranke space. On the left side, there was a complete ballooning of the epithelium, and so that suggests you that there is no involvement of the ligament, and it's safe to perform a subepithelial chordectomy, while on the right side, in this case, and anterior side of the lesion, there are some adherences, incomplete ballooning that will guide you to perform a subligamental cordectomy. And so this is this therapeutic algorithm for mid-cord early lesion erythroleucoplakias. So performing, so for a lesion with normal mucosal waves at the videolaryngostromboscopy and negative bioendoscopy, with the hydrodissection, you can guide your resection going to a type 1 cordectomy, or for lesion with an impairment mucosal wave of positive bioendoscopy or with an incomplete hydrodissection, this can guide you to perform a subligamental cordectomy that is safer. In our experience, we recently analyzed a cohort of patients treated in this way compared to a cohort treated without applying the saline infusion, and we saw an improvement of the adequacy of the treatment from 60% to 90%, just in terms of type of resection compared to a histopathologic result. And lastly, dealing with transoral laser microsurgery for the larynx is so relevant to have a nice crosstalk with the pathologist, as every specimen must be oriented and analyzed properly. So you need to receive from the pathologist information about all the margins, and it's relevant the deep margin, but also regarding the superficial margin, you need to know exactly which margin are analyzed, the superior, the posterior, the inferior, and the anterior. In the more conventional resection are these, the margin to be addressed. And the way can be done inking the specimen in the OR, but this choice must be done in agreement with your pathologist, that the best would be to have a dedicated and an pathologist, and to choose with him or with her the better way to study your specimens. And thank you for your attention. If you have any question, this is our team in Genova. And thank you also to other guys, to the residents that helped me for the building of this presentation.
Thank you, Dr. Musale. It was a nice talk, quite comprehensive one. Couple of questions. What's your experience been with the use of contact endoscopy and optical coherence tomography and stroboscopy? Any specific indications where you would look at using them?
Unfortunately, in general, we don't have any experience with contact endoscopy, and also with the current tomography. What I can say is about laryngostroboscopy, that as I said, is useful to integrate the information with the biologic endoscopy tools. So the answer to be addressed is the deep extension of the lesion. The laryngostroboscopy can't say you anything about the superficial spreading, but can give you, and this can be done in few seconds, because, for example, with the Olympus tools, with the same, also with other brands, with the same nasopharyngoscope, you can just switch the light source and push a button and turn on the stroboscopy. So it's all integrated in the same evaluation, and can give you some information about the deep extension. And so for this is useful, but it must be seen together with the other bioendoscopy tools and the full HD television endoscopy.
So finally, once you finish your evaluation, so what are the indicators, or what helps you decide that an early stage lesion needs to undergo laser surgery or a conventional therapy like radiation or something? What are the indicators that you look at?
Okay, this is a little bit outside from this talk, but anyway, the best indication for laser surgery is T1A. There are no doubts that in that case there are some benefits going to this kind of surgery. The doubtful situation could be a T1B with involvement of anterior commissure, and so every case must be discussed in a multidisciplinary team. Also, you need to see if you're faced with an old patient, with a young patient. You need to evaluate preoperatively the potential exposure of that patient, and of course there will be the talk by Cesare Piazza later on about that. And so yes, the sure indication for laser surgery is T1A, and other situations are more borderline and must be discussed.
So are there any recommendations for the minimum type of chordectomy that should be used in any sort of case, any suspicious lesion? So
type 2 chordectomy. If I see a suspicious lesion, so a mid-cord erythroleucoplakia with some suspiciousness by the biologic endoscopy, it's safer to go directly to a subligamental chordectomy, for example, with a normal mucosal wave. And so you don't think that the vocal ligament is involved, but the bioendoscopy suggests you the histology in terms of at least premalignant lesion. And so subligamental is safer, and as vocal outcome is as good as a subepithelial chordectomy. And sometimes also the vocal outcome is of a subepithelial is less predictable than a subligamental. So if you do a subligamental carefully without taking just the superficial facial layer of the muscle, not more, the vocal outcome is very good.
Right. Thank you, Dr. Misale.
You're welcome.
Right. Moving forward, the next talk would be by Dr. Farouk Rifat from Australia. He'll be talking on the role of a multidisciplinary team in transoral laser microsurgery for early exotic malignancies.
Thank you, Anand. Thank you, Akshay, for having us over. Let me just load up my slides. And following on from our previous speakers, Carsten, Alok, Francesco, I think you'll find inevitably there's always a little bit of repetition in these talks. And while repetition can reinforce learning, I do apologize if I'm repeating some of the points. So my talk for today is about the role of the multidisciplinary team in transoral laser surgery. I'll try and review our experience of 130 cases that were originally performed by Dr. Palm, and then subsequently myself joining the unit about 8 years ago. And we've analyzed some of the data and we've published some of them. And over time, we've deciphered the key role of the multidisciplinary team in achieving success. So one of the first things you don't want to do when you set up an endoscopic laser service is that you don't want to be flying solo. This is not something you can do by yourself. And really what you need is a happy team. And that team includes doctors, nurses, and allied health professionals. And we'll talk about each of them as they come across in the journey of our patients. So again, my one disclaimer is we're not going to discuss anything on photoangiolytic lasers. This is purely talking about a CO2 laser service. And this diagram you might have already seen from my colleague's earlier slide, but it talks about the various individuals that really play a part in allowing you to achieve success with your patients in terms of outcomes. And they include multiple members of the staff, our oncologists, our institutional members, allied health professionals, and our research and audit staff, including our registrars who work hard to get a lot of our data together. So This is a picture of our MDT meetings. Of course, nowadays, because of COVID, they're all done virtually, but we meet on a fortnightly basis, sometimes on a weekly basis, in order to discuss all new cancer patients, including patients who are being followed up. And really, our MDT is involved in both the diagnostic stage, the treatment stage, as well as the really important part in laser surgery, which is the rehabilitation of patients, particularly voice rehabilitation of patients. And of course, the unsung heroes of our MDT, which include our cancer coordinators, our junior medical staff, our nursing staff, our data managers, research assistants, notwithstanding the families and carers of our patients. So we will look at the journey of a lesion. I thought this might be the best way to actually see the interaction of the various members as they come along in the journey of an average lesion that we see. This is a T1 lesion of the larynx, or we think it's a T1 lesion. At this stage, this lesion hasn't been biopsied. So this is a hoarse voice over 6 weeks in a 30-pack-year smoker, referred to our clinic. And at this point in time, of course, when we assess him with a combination of video endoscopy, stroboscopy, and narrowband imaging, which I agree with our previous speaker, is evolving and proving to be more and more useful in optical diagnosis of lesions. The key questions in our mind is, number one, what's the pathology? Number two, any treatment that we perform, what impact that may have on both the patient's oncological outcomes and non-oncological outcomes, what may be an appropriate modality for treatment, and of course, advising him regarding smoking cessation, because as we know, for both benign and malignant and pre-malignant lesions of the larynx, one of the key factors that affect outcomes is whether our patients continue to smoke. So moving on, we've now examined this patient, and of course, one of the key things we want to do as surgeons is to obtain the diagnosis, and that involves finding the pathology. Now, there are various different ways of doing it. The smash grab technique, which really I wouldn't recommend, is unrefined. It does result in sulcus or a scar formation between the epithelial and the ligamentous surface. And these patients can have poor voice outcomes. And again, there are many different areas that this talk can possibly go into, but without digressing, one of the reasons why a lot of patients, even with a very minor biopsy, can actually end up with a poor voice outcome is the formation of vocal scar or a sulcus as a result of a very aggressive biopsy. And these can occur even if the patients have radiotherapy. So smash grab biopsies, certainly not to be encouraged. Transoral laser microsurgery is one technique. Cold steel can easily be performed. And of course, there's the concept of whether the lesion should purely be sampled or whether this should in effect be an excisional biopsy, which may actually be complete treatment. And I think one of the nuances in laser surgery is that a lot of that depends on the expertise of the surgeon in terms of assessment, in terms of surgery, and of course, in terms of the MDT discussion with the patient regarding what would be more appropriate. As our previous speaker highlighted, I do think hydrodissection is very useful, as is the creation of a microflap. And again, what you want to do is minimize vocal morbidity to the patient and achieve a good oncological outcome. This is, of course, assuming that this is a cancer. So even purely at the stage of obtaining a biopsy in all these different techniques that are available, at this stage, a speech and language pathologist can come in and assist you in this decision-making. And the reason why is because when you do a pre-treatment laryngostroboscopy in a voice clinic, and this is the ideal gold standard, because what you want to analyze even before you touch the patient in the operating room are things like the vocal demand of the patient, are things like the occupation, are things like whether there may be any concurrent factors that may contribute to laryngeal inflammation, including rhinitis, including reflux. And in our multidisciplinary voice clinics, our speech pathologists will perform a combination of stroboscopic objective analysis in addition to perceptual voice analysis, both of which will be important in guiding our patients and guiding the clinicians in terms of what may be the most appropriate. So you can see here that the technique of biopsy that is employed, and this is not being ageist or anything, but the technique of biopsy that you may employ in an 80-year-old heavy smoker who is currently not working and enjoying his retirement would be very different to a biopsy that you perform in a 30-year-old lawyer or teacher whose occupation depends on phonatory use. If you give them a bad voice outcome, regardless of what you may do, achieving good oncological outcomes may be insufficient in giving you patient satisfaction. So you can see here, the speech pathologist plays a role even before the treatment has commenced. And of course, in our unit, our speech pathologist and us, we've looked at our data in terms of complications, in terms of voice outcomes, and we know that preoperative and rapid postoperative voice therapy actually does improve outcomes, both in terms of speech and in terms of swallowing in other laser cases, not specifically referring to early glottic cancers, but piriform fossa cancers or more advanced laryngeal cancers. Now, you then take this patient to the operating room, and this is where the second element of the multidisciplinary team comes in, your anesthetist. You should ideally only work with one anesthetist, but certainly an anesthetist who's dedicated and able to manage the shared airway with the ENT surgeon or the laryngologist in this case is absolutely vital. And that's because there's a whole myriad of anesthetic techniques that can be employed in performing laryngeal surgery. That can include Thrive, jet ventilation, both supraglottic and infraglottic jet ventilation, as well as the laser safe tube. I won't go into the merits and demerits of each of these techniques, but of course, whatever you do, you need to be familiar with, your anesthetist needs to be familiar with, and ideally, even before the start of the case, you want to do a complete team brief where the entire anesthetic and airway management plan has been highlighted to everyone in the operating room. Now, this is a balance between operative safety, laryngeal exposure, and you want to achieve the right balance in obtaining the lesion, in obtaining a complete treatment, but of course not compromising any safety. So the laser safety officer, as has been mentioned earlier, is again separate to the surgical team. You want to minimize the number of personnel within the room, make sure you have complete airway fire precautions, make sure that the team and all the members are aware of the airway fire precautions, the eye protection, the testing of the machine, the deactivation of the machine when it is not in active use to avoid inadvertent activation by the surgeon in a difficult case. And of course, our nursing team and this operation, as has been mentioned earlier, should really be demystified for the nursing team. You want to have a consistent draping technique, video documentation for every case for posterity and comparison. And of course, the more familiar your anesthetist, your nursing staff, and your laser safety officer are, the better and the smoother the overall case will be. And the smoother case equals greater satisfaction for the surgeon, and a more relaxed surgeon results in better outcomes. The last thing you want is for the logistics of the case to be the biggest source of grief for the surgeon. So you can see here again, multiple members of the team interacting to achieve a good outcome in the operating room. This diagram you may have seen earlier is from my colleague's slide. This is the way we set up the theater with the surgeon at the head of the bed, the nursing staff on one side, the laser safety officer, our anesthetist, and of course our video documentation source. And whatever system you use, as long as everyone is consistent, as long as the same method is done every time, I think beyond the early learning curve, you should all be able to achieve similar outcomes. So now the lesion's out, and as Francesco pointed out earlier, there are various different ways of highlighting this to our pathologists. So this is another member of our multidisciplinary team and probably one of the most vital members. Now, whatever you do, whether you use a Mohs style, a margin mapping, which I tend to favor, or whether you use a corkboard or cucumber pinning, you and your anesthetist, you and your pathologist need to be on the same page. You need to communicate with them so that they can interpret your specimen in the context that you have operated on. So you need to have a dedicated pathologist who's familiar with the nuances in laser surgery, including the concept of piecemeal resections. In margin interpretation, you need to picturize your specimen, communicate, orientate the specimen for them, because any margins that are provided will be absolutely meaningless unless it's interpreted in the clinical context. What do we want from our pathologists, and what do they tell us? The pathologist wants to tell us what this lesion is, and if it's malignant, we'd like to know the type of malignancy, the grade, the margin, whether these are discohesive cancers or whether they are cohesive cancers with fronds of tumor. And of course, you want to correlate the clinical settings and the operative finding to allow meaningful interpretation in the MDT. But what does the surgeon want to know? It's slightly different to what's often written in pages of pathology reports. We want to know, number one, have we got the lesion? Are our margins clear? And you need to have a surgical gut feeling, and you need to combine that with what your pathologist is telling you. And if in doubt, go in and have a second look. You want to know whether you need to go in again. Now, in malignant cases, in many units, including certainly in my practice, it's routine to go back in again and do a second look at approximately 6 to 8 weeks. But of course, what you want to now think about as well is whether doing further procedures, assuming now this is a T1 vocal cord lesion, what you want to now know is whether doing further procedures, if your pathologist tells you your margin is closed or involved, or the deep margin is involved, you may now need to progress from a transligamental to a transmuscular resection. And of course, in order to achieve that margin, you may now scar the vocal cord further. You may then this may then result in postoperative vocal cord glottic insufficiency or failure of closure, and a glottic gap that results in a breathy voice. And you can see that the nuances of the decision-making are not so simple, because now you need to consider whether radiotherapy should also be considered as an option for this patient compared to further surgery. And of course, this talk is not about radiation versus surgery, so we won't get into that, and different speakers will talk to you about that. But this is where you now need to have your MDT discussion, which is the radiation oncologist, the radiologist, the pathologist, and the surgeon having a discussion about how you may best achieve the outcomes for your patient. Now, in early vocal cord cancers, as our previous speaker highlighted, there's very limited role for radiology, unless you have a feeling that this anterior commissure lesion may have breached the natural barriers of spread and have entered the pre-epiglottic space, in which case the tumors are getting upstaged to a T3, or whether there is paraglottic space involvement. And I think in those cases, patients may not be suitable for curative intent transoral laser surgery unless in very experienced hands and very experienced units, because in effect, the radiology is upstaging the tumor. But in early glottic cancers, there is very limited role in radiology. So the radiation oncology is not your rival. The radiation oncologist is not your rival. It's your key, he or she is actually your key ally in achieving good oncological outcomes in transoral laser microsurgery. So it's not an us versus them approach. In our unit, it's quite collegial. You want to have a decision-making paradigm, whatever you may choose, in order to achieving the best outcomes. There are, as you know, trials or groups that report better outcomes with laser surgery. There are groups that report unequivocally better outcomes with radiotherapy as far as voice is concerned. But I think you need to have your own unit-based experience as to what you think may be better in your unit with the expertise that you have. Because the indications for radiotherapy in early glottic cancers can vary between different units. There are patient factors that you need to take into account. That includes, as we mentioned before, if they're a professional voice user, are they a smoker? What's their motivation for giving up smoking? Because again, if they're a smoker and they are going to continue smoking, their chance of having a second primary or a recurrence within the larynx or a second upper aerodigestive tract primary, as Alok and Carsten highlighted earlier, can be in the range of 10 to 15%. So these things need to be taken into account, besides the obvious age and surgical comorbidities. But in transoral laser surgery, comorbidities are not really a major factor in the vast majority of patients, neither is age. But there are disease factors that may be more suitable, that may make certain lesions more suitable for radiotherapy. That includes multifocality, and upgrading of the lesion in terms of its staging after the examination under anesthetic, anterior commissure involvement, that's a relative contraindication, the need for repeated treatment. Now that can be again due to oncologic factors or technical factors. So some patients, due to difficulties in laryngeal exposure in laryngoscopy, it may not be possible for you to achieve adequate exposure despite your experience, despite little tricks that you may have to improve exposure in order to obtain adequate exposure to the anterior commissure, in order to obtain sufficient clearance of margins. They may have trismus, they may have large incisors. We won't go into the predictive factors for a difficult laryngoscopy, but these are well published. And so that may be a technical non-oncological factor that may result in patients getting radiotherapy. If the margins are repeatedly not clear or tumor fronts are discohesive, that may mean once again that you're less likely to achieve curative outcomes with surgery alone. There are, of course, surgeon and institutional factors. Certain institutions are very surgically biased. That could be personality of the surgeons, that could be a bias of the institution, and certain institutions equally are very radiation oncology biased. Of course, your surgeons performing this need to have fellowship training, need to have expertise, need to have the equipment, the institutional support, and of course need to have the honesty and the probity to have their own results analyzed, published, presented, and scrutinized. So now our treatment is complete. So we have this lesion has been removed, has been discussed in the MDT, and thankfully we have obtained clear margins. And this is the T1A vocal cord carcinoma. And now our nursing staff who help us organize our follow-ups, provide the support to the patient. It's well known that nursing staff directed encouragement of smoking cessation achieves greater success. And this is absolutely vital in terms of preventing not just recurrence, but progression to subsequent primaries or even other digestive tract malignancies. The nurse is the link between the patient and the clinician. Often you'll find that patients reveal things to our nursing staff regarding their concerns that they may not be able to voice in their fleeting short consultations with us. Our audit and data managers keep us honest. They allow for prospective data collection, for research, for presentations, for publications, for quality assurance, and of course for partaking in clinical trials. Our speech pathologists get involved once again in post-treatment because there is some evidence emerging that vocal cord pliability improves with early post-treatment speech pathology. It results in a reduction of vocal cord scar between the epithelial surface and the deeper layers, and perhaps may improve vocal outcomes. So we often get them involved, particularly in the treatment of post-surgical glottic insufficiency. They also play a part in the long-term vocal rehabilitation of these patients. Now, there are further talks on this, so I won't dwell too much on this, but there are basic principles of managing reflux, managing rhinitis, reducing, this is the immediate period, making sure that they're well hydrated, avoiding vocal overuse, speech pathology as we talked about. But of course, beyond the early cancer surveillance period, now different people have different opinions as to when vocal rehabilitation can be considered. But certainly if you are going to just perform injection augmentation of the larynx for treatment of post-laser glottic insufficiency, then at 1 year mark or 18-month mark, injections are probably doable, assuming that your pathology was clear and your surveillance is okay. But a lot of patients with the passage of time do develop physiological compensation in follow-up and surveillance. What you find is a lot of patients who have significant secondary strain from muscle tension or breathiness from glottic insufficiency actually improve with physiological compensation over time. So it's important to realize that yes, while a lot of patients may get an early a relatively poorer voice outcome over time, things compensate, and on balance, it may be more appropriate for them to have transoral laser versus radiotherapy, assuming all other factors are okay. Part of the MDT, of course, part of the multidisciplinary approach involves education of your colleagues. Now, many of your colleagues who work in general ENT may not be averse with the latest techniques of hydrodissection, of laryngeal biopsies, and so on. So performing courses and proctoring and peer review of results and publishing your findings are absolutely vital. Because that's how your colleagues, for example, find out that just a simple smash and grab biopsy is a bad thing to do. And so it might actually result in more early referrals before interventions, because if your colleague who refers you the patient has already performed a significant biopsy, which has resulted in a sulcus, which has resulted in a big dent of the vocal cord by the time the patient comes to you, even the best hydrodissection and scar excision techniques may not save the patient from a poor voice outcome. So remember that success in transoral laser surgery requires a multidisciplinary approach. You've seen in the journey of my lesion how our colleagues and our entire team get involved from the time a lesion is seen to a time a lesion is operated to a time a lesion is rehabilitated, and with further follow-ups in the community. So please do not fly solo. Thank you.
Thank you, Dr. Rifat. It was an interesting talk, and it was nice of you to highlight the importance of a team effort to get the best outcomes. And another important point that you had touched upon was the role of the speech language pathologist early on in the treatment. Like often it happens that the patients are referred to him at the end of the procedure or after the procedure for the rehabilitation. Involving them early brings in a lot of changes in terms of the outcomes and how they would follow the patients. There are a few questions a little outside your talk, but if you could answer them. So one was from Professor Thakkar. Your thoughts on the use of Thrive in transoral laser microsurgery. There have been concerns about its safety, alternatives and others.
Yeah, I agree with Alok. I think, the usage, remember from Carsten's talk, that to have an airway fire, you need three components. You need fuel, you need oxygen, and you need, so what you lack in Thrive is the fact that there is no secondary combustion source in the airway. You can use Thrive. I know it's an off-label indication. You just have to be careful regarding the oxygenation levels in reducing it and stopping the Thrive during the procedure itself. We do allow, even after the Thrive is actually stopped, before commencing laser, a certain short period of time to allow for diffusion. But the third thing I'd mention that's really important is that Thrive actually creates a plume around the patient. And the risk of fires is probably greater in the drapes around the patient, because you may read there are some very good descriptions and talks about how Thrive, in effect, while the surgeon is focused on operating on in the airway, the Thrive itself creates a cloud of oxygen all around the patient, and a little combustion from your monopolar diathermy or from scatter of the laser, which hopefully doesn't happen, can result in a nasty fire on the periphery rather than the airway. Look, I personally think if you are going to use Thrive for laser, you need to be really cautious about your peripheral environment besides the airway, which you don't normally focus on. You need to make sure you give adequate diffusion time to allow the oxygen levels or the high oxygen levels in the airway to taper off a little bit before you commence. But remember, there is no fuel to burn in the airway, assuming that you're doing it with a tubeless technique.
Can I make a comment?
Yeah,
sure, Carsten. Yes.
I think that we should not advocate using Thrive and CO2 laser treatment of head and neck upper area digestive cancer. It needs to be done in a very highly specialized, high volume setting with people who do this regularly. And like a lot of things we do, it's a blended approach. It's using different techniques at different stages of an operation. I think Thrive is a wonderful technique of putting the patient to sleep. It's a wonderful technique to assess the cancer, but we would not advocate the use of Thrive during the process of laser resection, because as Farouk said, it's not so much the fire in the airway, but it's the fire underneath the patient because of pooling of oxygen and under the drapes. And in fact, that's one of the biggest sources of complications. So I think we want to be really clear. We are not advocating using Thrive at the time of CO2 laser resection.
Also, do you suggest that every patient who could be a potential candidate for a transoral laser microsurgery undergoes a multidisciplinary tumor board kind of a discussion before he's actually wheeled into the OT?
Look, I think it depends on your circumstances. Look, I think what I gave the talk was on what probably we should all aspire to. That should be the gold standard. And I think if the resources of your department and your laser service and your MTT permits, then I don't think it's a bad thing, because I think it'll definitely improve outcomes. Whether that's practical or not, I'm not sure, because then you'd have to look at your local circumstance. I do, however, feel that every patient needs to be given the option of a comprehensive discussion with a laser trained surgeon, as well as a radiation oncologist, regardless of how simple the excision may look. And that's because I don't think we are in the best position to advise on what they do and the outcomes that they achieve, as much as they are not in a position to tell the outcomes we can achieve. We all have a general idea, but I think it's in a true, honest MDT. I think both options should be presented to the patient. Look, it's horses for courses. There are certain cases where clearly radiation is better suited. There are certain ones where clearly our approach is better suited, but there is no one best technique. So I think the answer, whether every cancer should be discussed, I think every cancer needs to be discussed. Does every lesion need to be discussed? I don't think every lesion is, I don't think based on the volume we see, I don't think it's practical for every lesion to be discussed. But I think at the back of your mind, you need to have the factors like the voice demands of the patient, the occupation, and all these things. You know, I'm sure all of us here have done cases where we have achieved great oncological results. And I know I can remember the faces of the patients that have been extremely unhappy with the quality of their voice afterwards. And I think sometimes in our rushed cancer clinics, we don't actually sometimes realize what jobs our patients do and what those jobs actually entail and so on and so forth. So I do think, you know, if you get them seen by a speech pathologist, that is ideal, and see them in a voice clinic, that's even better.
Thank you for the talk. We don't have any more questions for this session, so we move on to the next talk. So the next talk is by Dr. Akshay Kutpaje. So he'll be talking on how a primer should set up a laser, modular laser center, talking about the instrumentation, the anesthesia, and what all equipment. It's basically a primer's guide.
Hello?
Yeah, they're audible, sir.
Just share my... So can you see my screen?
Yeah.
Right. So my topic, as Dr. Rifat mentioned, that the talks have been excellent. We had been a very elaborate discussion on the early glottic cancers. As Dr. Rifat mentioned, my talk I think is going to be a repetition, but I thought it will be like a perspective from my point of view of setting up a laser center. So coming to the early glottic cancers, the treatment options are external beam radiotherapy, surgery in the form of conservative laryngeal surgery, or transoral laser surgery using carbon dioxide laser. So external beam radiotherapy has been practiced across India, centers having all radiation facility do practice external beam radiation. Coming to conservative laryngeal surgery, it is a little morbid surgery. That means it needs an external incision, need to split open the thyroid cartilage, enter the larynx, remove the tumor with margin. And this leads to significant functional problems and morbidity. Over the last 3 to 4 decades, there have been significant advances and documented evidence to say that the transoral laser surgery is oncologically sound and functionally appropriate if you select your cases correctly. So the advantage of transoral laser surgery, it's a minimally invasive surgery. There's no need to cut through the external skin. It is usually performed through the mouth without the needing of external incision. As a result, the functional recovery is excellent with a minimal morbidity. These patients stay in the hospital for a very short day. Majority of them are done as daycare procedure. As a result, so transoral laser surgery is definitely a preferred surgical option in at least T1A lesions with experience, probably taking into account the occupation and other patient factors. It can be extended for select T1B or a T2 lesions without much of a subglottic extensions. So to run the endoscopic laser service, as alluded by Dr. Rifat, Professor Carsten, it's a multidisciplinary team. It's not a one-man job. You need a support of multiple disciplines to run this program successfully. The most important discipline is, at least in Indian setting, is the infrastructure and the institutional support. So we need some basic instruments to, in terms of instrumentations, we need the standard laryngoscopes. But what is important to perform in transoral laser surgery, especially of the vocal cord, the Dido laryngoscope having in the armamentarium is a very good laryngoscope to have when you're performing surgeries on vocal cord. In addition, you need to have a series of Klein saucer laryngoscope with a matted finish, which helps in reduced reflection of light of the laser. In addition to that, you need to have a chest support to put this laryngoscope in the suspension so that your hands are free and you can work with the laser and the suction to perform these surgeries very smoothly. So the chest support usually have an adjusting supporting plate, and that helps in maneuvering in difficult situations, especially the anterior commissure extension or a little bit of a supraglottic extension. You need to have a standard set of microlaryngeal instruments, the grasping microlaryngeal instruments, the right, left, upward, which are atraumatic. In addition, the suction is the most important thing. When you're performing little extensive surgeries involving the anterior commissure or the arytenoid, where you encounter some amount of bleeding, you need to have the suction cautery. You can have a monopolar cautery and a bipolar forceps as well as a part of your instrumentation set. You need to have a standard laryngoscope, the standard microscope with a provision to attachment of the micromanipulator, and a smoke evacuator helps a great way in reducing the fumes as well to conduct this procedure smoothly. Instrumentation, in terms of the laser machine, two main companies which market the laser machine are the Luminous and the KLS Martin group. And these laser machines are very versatile, meaning this laser machine can be used as a free beam. It can be used as a contact laser with the help of a fiber, which can be channeled through the bronchoscopes, or with the handheld attachment. It can be used to perform surgeries on the oral cavity or the nose, etc. So in terms of the precision, if you get the focus right, you get the settings right, so you get a very focused beam, and with this beam, with a good exposure, you will be able to remove the lesions in the vocal cord without causing much of a collateral damage, and as a result, we can have an excellent outcomes. In situations where you cannot see the lesion with the simple suspension laryngoscopy, especially in lesions with subglottic stenosis, short segmental stenosis, or a pedunculated lesion the subglottis or the trachea, the fiber facility with the laser machine helps us to reach these inaccessible areas and do the surgery. This case in point was a subglottic stenosis short segment. We were able to do a cruciate incision of the subglottic stenosis with a balloon dilatation with the help of a pulmonology colleague and achieve a good outcomes. As alluded by other speakers, training forms a very, very important part of this service. Preferably, the surgeon should be from an otolaryngology background with a basic head and neck training, and a 1 year of fellowship training in this laser surgery will help a great way, because otherwise there is a significant danger to the patient as well as to danger to this technique being faded away if you don't choose and practice these surgeries appropriately. And this has been studied. When you look at outcome, learning curve, whenever a new technique comes, if the surgeon is not properly trained, the outcomes dips down significantly. So it's very important to get a proper training. And in our center, we have a division of minimally invasive head and neck surgery with robotic surgery, transoral laser surgery, as well as endoscopic skull-based surgery. And in this, our trainees get an opportunity to participate actively in all the cases, and they get a basic understanding of how to perform these cases. In addition to this, we run annual meetings on minimally invasive surgery. November was the meeting. We had a live meeting with Professor Palm, had been invited here, and he performed some beautiful surgeries here with us. And this year, in view of this COVID situation, we were not able to do this, but with this online platform, we were able to educate with this meeting. Anesthesia team importance cannot be, it's very important, because the vocal cord is that area where it's a shared region. It is a trade-off between a safe airway ventilation versus adequate surgical recess. So understanding between the surgeon and the anesthetic is very important when you're performing transoral laser surgeries. The choice of the technique is dependent on the experience of the anesthetist, anesthesia team, the equipment available, and in certain situations, our anesthesia colleague devised some creative solution to overcome these difficult airway situations. All of the patients, before we take them to the operating theater, a day prior, we have a consultation with our anesthesia team with the flexible endoscopy to kind of assess the extent, look at the airway patency, and then plan the type of anesthesia accordingly. So the type of anesthesia available for transoral laser surgery are the closed system, which is preferred in this COVID era, or the open system. The open system includes jet ventilation or intermittent apnea. In the closed system, we can use a simple endotracheal tube, microlaryngeal tube, or a laser tube. So these are the range of tubes which have been tested, from a red rubber tube to the laser resistant laser tubes with double lumen cuffs. However, our preference in our unit is to use a microlaryngeal tube. Number 5 is what we prefer at our unit. So we use a number 5 endotracheal tube. So here what is important is we need to inflate the bulb with a methylene blue dyed solution, so that if at all accidentally if we hit the bulb, then we can notice it early and change the tube appropriately. So when the positioning of the endotracheal tube also, we place it well below the subglottis so that it doesn't come in the area of our surgery, and we usually place neuropathy, which is moist, below the free edge of the vocal cord to prevent any damage to the cuff. In situations where the lesion is obscuring the airway, or in situations where we have difficult exposure, whatever anesthesia headed by Dr. Rajesh does is that they do a percutaneous tracheostomy on table. So whenever the difficult exposure is there, we plan for a percutaneous tracheostomy. Normally, all of cases are done as day care procedure. However, in these kind of situations, when we are planning for a percutaneous tracheostomy, we keep these patients in for a day. The reason for this is that even though we remove the tracheostomy tube at the end of the procedure, there is a chance of having a subcutaneous emphysema, and our patients will not be very much trained to manage it. And we use time overnight and the next day to educate our patients about the small chance of the subcutaneous emphysema, reassure them, and help them managing these situations. Usually when these patients come back for follow-up, it is like the scar is hardly visible, and we have been having a reasonably good outcomes in these kind of patients. We have an experience of about 12 cases now. So this is acknowledgements to my anesthesia team headed by Rajesh, who always are ready to give any difficult cases to help perform these operations. The nursing team is very important. All our nursing and the technicians are well trained to carry out this procedure in terms of setting up the laser for us. So we always test the laser before the patient is wheeled into the operating room. Sometimes he may have technical issues and we don't want to encounter that problems. As a result, before the patient is wheeled into the operating room, we check the settings of the laser. So we put the micromanipulator to the slot in the microscope. We connect the required connections between the laser machine as well as the micromanipulator in the microscope. These laser machines, as I told, are very precise, safe, and very easy to use, provided you stick to the basic rules. So we have a luminous equipulse DO laser system in our hospital. So this is the simple setting. We use a AccuSpot 400 is what is preferred for the larynx. And in terms of the laser settings, the preference for vocal cord surgery is the super pulse continuous mode. And my preference in terms of shape is either a round or a line with the smallest size possible. So I set it for a 0.3 millimeter, and the power I set it for a vocal cord for it at a 4 watt power. So once the patient is anesthetized, all the safety precautions taken, so we place the patient supine with the shoulder roll back with the head ring to put him in the appropriate position for laryngoscopy. So it is advisable to use a cloth drapes, but however we use the standard drapes, but what we do is we use wet mops around the laryngoscopes. Once this is done, we suspend the laryngoscope. Once we have a good exposure of the lesion, then we suspend the laryngoscope to have so that our hands becomes free. All our patients get as Francisco alluded, all our patients get a check endoscopy. We use an endoscopy specifically to look at the subglottis, the anterior commissure, the ventricle, and in situations we can also using a cystoscope, which is about 40 centimeter in length. We can deflate the cuff and also do a bronchoscopy in the same sitting to rule out any second primary. This also helps us to photo document the lesion and helps in better counseling to the patients. Once we have an adequate assessment, comfortable about the exposure, then we go forward to plan our laser excision biopsy. So since the laser is a line of sight, so you need to have the microscope, the laryngoscope, and the lesion in the straight line. To accomplish this, we elevate the head end of the back of the bed so that all of these are in the straight line. We keep the working distance between 430 to 480. Accordingly, we get the laser beams micromanipulator setting according to the working distance until we get a clear focused beam. We use just a Mayo stand with the sterile drape to use it as a support if you're performing certain extensive surgeries. Maybe if it is taking more than 15-20 minutes, I prefer to keep a Mayo stand for supporting my hand. So once the laryngoscopy is suspended under microscopic, with the help of an assistant, you give an external pressure to look at the anterior commissure to see if you can get around the lesion completely. And with the focused laser beam, we go ahead and perform the procedure. I usually start from the anterior part of the lesion. So go to the anterior commissure area, depending on the extent of the lesion, work around it, and then accomplish the excision based on the extent. So it's very important to place a wet neuropathy below, otherwise there is chance of inadvertent damage. Once the specimen is excised, it is very important to orient it properly, because these are very tiny specimens. If you don't orient these specimens appropriately, we'll not be getting accurate pathological information. How we do it? We just ink the margin. We use a simple pictorial represented liquid paraffin block, and we use colored pins to pin the anterior, posterior, medial, and lateral end. This importance of the communication between the surgeon and the pathologist is very important. The first step in pathology starts by the orientation by the surgeon onto the paraffin block. So we subject all our patients with vocal cord surgery for frozen section analysis. I know in literature, there is no much evidence favoring frozen section, but in our experience, we have found that frozen section has helped us in a great way in counseling our patients. After the resection, we do a check endoscopy, again to photo document the lesion, have a look at the bed of the operated bed, as well as to assess the lesion appropriately. If at all we see a charring in the bed, so we use a wet neuropathy and remove the carbon particles, because this carbon particles, if not removed intraoperatively, lead to significant post-operative granulation formation. So as a result, after excision, whenever we find that there are carbon particles in the bed, operated bed, we use a wet neuropathy and make sure we remove the how much ever carbon particles can be removed. So understanding between the pathologist, as I told, is very important. So we take the specimens ourselves to the pathology when the patient is still under anesthesia. We help them orient them with inking with appropriate colors. We have a standardized way of reporting, sampling these ones. And once the specimen is appropriately oriented, it is subjected to the process, histopathological process. They slice it. Once they get an adequate, the best section, they do the hematoxylin eosin staining and help us understand what the histopathology is, and if the histopathology is squamous cell carcinoma, whether we have got it out completely. Because these are the patients, early glottic cancers, we should be treating it single modality. The margin is so important to cure these patients. So that's the standard staining formalities. And that's how they let us know whether it is a squamous cell carcinoma, if it is squamous cell carcinoma, if we have got it at all margins clear. So what is important for us is the deep margin or a multiple superficial margin. So if since we are doing these surgeries under microscope, if we have a single superficial margin which is close, that is fine. We can still observe the patient if during the operation we feel that we have got it out completely. But if we have a deep margin positive, or if we have multiple superficial margin positive, that is when we have to either re-laser these patients, or certain patients which are extensive, we may have to consider for radiation. As you all know, the margins are just about more than a 1 millimeter is clear margin, unlike 1 centimeter in rest of the head and neck. The contribution of speech and swallowing pathology is very important. So we do a preoperatively counseling to all our patients with the help of the speech and swallowing team headed by Mr. Prasanna. So we take into factor the habits, we take into factor the occupation, comorbidities. We discuss the extent of resection along with the patient, with the swallowing specialist. We preoperatively do all the subjective as well as objective analysis, and postoperatively we subject these patients to regular follow-up with the swallowing team. We get weekly, we have a first consultation the 7th day, then after 2 weeks and every 3 months, and the voice exercises, everything are taught to them to achieve the best outcomes. So this is our data on laser surgery. So we do about, over the last 2 years, we do roughly about 35 to 40 cases a year. So finally, to conclude, to achieve the best outcomes in transoral laser surgery, we need to have a multidisciplinary team approach involving all the disciplines involved, taking the patient into confidence, taking his expectation into consideration. Proper case selection is key, and we can achieve best outcomes for better training and educational activities such as these. Thank you.
Thank you, sir. Interesting talk for a beginner. Just a couple of questions. So we did speak about the margins and how the frozen section helps us. What is your take on relook surgeries or second look surgery?
Right. So regarding relook surgery with the advances in narrowband imaging technique, so it is not a standard practice in our unit to do a second look in all our patients. So we base our decision for second look based on the finding of narrowband imaging. So granulation is a problem in the post-operative period. So we try to reduce the granulation and by, as I told, to remove the carbon particles from the operated bed. But as a standard, we don't follow a second look procedure in our transoral laser cases. We base our decision based on narrowband imaging findings.
Sir, also angiolytic lasers have better vascular controls compared to carbon dioxide lasers. What is your take on, like, what additional precautions do you take to when there's a bleed or anything? Right.
So in terms of vocal cord surgery, the best laser is the carbon dioxide laser. So angiolytic lasers are useful for a supraglottic lesion or a base of tongue lesion when you expect more vascularity in that region, and it is not a very fine structure, because as you know, the absorption, the laser gets absorbed by the hemoglobin, and as a result, the damage is a bit more in angiolytic laser. I personally don't have experience of using angiolytic laser, but for vocal cord surgeries, it is not preferred. If you have a carbon dioxide laser, that is a better technique, because the outcomes are much better for vocal cord. But it's a good tool to have in your center to carry out the supraglottic or a base of tongue site.
Do you use cautery routinely?
I think Karsten wants to make a comment.
Can I make a comment?
Yeah.
I think bleeding in a pure glottic laser case is really not so much of an issue. I think actually you mentioned the supraglottis, and I think that's right. And when you're going to do that, you've just got to actually clip the actual feeding vessels. I don't think the laser is going to make bleeding less or etc. I think in the true vocal cord laser, there are two sites where there's bleeding. One in the anterior commissure region, where you can get some small vessels, and certainly around the arytenoid cartilages. And very precise cautery, can be done. And I would agree. In terms of angiolytic lasers, I think they're great for superficial lesions. In terms of starving their blood supply. But as I said before, one of the fundamentals problem with angiolytic laser is that you don't have a specimen that you can analyze the margin. And that what we've said before, one of the key factors is margin status. A comment about second look. I would encourage people who are starting out this technique to routinely do a second look, right? To learn how things heal and to make sure that they're getting it right. I think once you gain experience, just like Akshay and other people, second look becomes less and less important. But I think when you're starting off, I think a second look is worthwhile. And certainly in my experience, that's what I did. For the first 40 cases, 50 cases, I always did a second look.
Okay. Thank you, sir. Thank you for the talk. I think we'll move on to the next talk. So the next talk is on potentially malignant lesions of the larynx and evidence-based approach. Talk would be delivered by Professor Vishal Rao.
Hi Anand, I'm ready with the talk. Just give me a second. Yes. Can I share the screen?
Yes, sir.
Okay. just starting the presentation. Just give me a second. So very good afternoon to all of you. Are you all able to see the screen, Anand?
Yes, sir, we have seen.
Okay, so I'll start off then. A very good afternoon to all of you. At the outset, again, I thank the entire team of HCG, especially Akshay, for taking this lead on this interesting topic and bringing this discussion to light for all of us. So today I'll be speaking to you all about potentially malignant lesions of the larynx and an evidence-based approach towards vocal fold leukoplakias. And I again, just to briefly introduce my organization, I'm representing HCG. We are a chain of cancer centers. We primarily focused on cancer, but we also have a presence in a small way in fertility. We have a separate, very large wing of precision medicine, which is Strand, which deals with bioinformatics, diagnostics, research, clinical trials. And we have our multi-speciality, which is again a very small wing of HCG, but an existing wing. We currently are at about 26 centers across the world. We've recently entered into Vietnam, Africa, and we went publicly listed in 2016. So from there on, we've been steadily growing and focusing our main area in cancer. At HCG, we have a comprehensive program for head and neck oncology fellowships, which is also affiliated with the Royal College of Surgeons and the state government health university. So if anybody interested in pursuing fellowships, please do reach out to our department. I think Akshay must have told you, we are also initiating a complete specialized course for minimally invasive surgery. Akshay is taking the lead as the program director for minimally invasive surgery, where we're going to be focusing a complete exclusive course on lasers with hands-on trainings. We've recently initiated some trainings in the Nature Masterclass, which is a certified course of HCG collaborating with Nature publications to look at scientific writing. So if any of you are interested, we are currently offering these courses to our participants free of cost to encourage the academic research. This is a very comprehensive course. I'll talk about it a little later. So today, what I would like to share with you all is very broadly some of the things on the aspects of potentially malignant lesions. The reason we've put the title as potentially malignant lesions is it kind of covers a broader spectrum and a gamut of these pathologies. So what I intend to share with you in the next couple of minutes is to divide it into the biological advances and into the technological advances and see how we can bridge the two and what is it that we've done. So without much ado, I would like to first draw all of your attention to this particular two diagrams. Now, what is interesting here is that we've, at least in India, we've given a lot of emphasis to the oral cavity because majority of our cancers in India comprise of the oral cavity. Even if you look at, let's say, 100 of the cases of head and neck cancers, you'll see as high as 70 to 80 of these cases would be related to the oral cavity, and only about 20% of the rest are related to other areas. So head and neck cancers again have a lot of emphasis in India given on oral cavity and less emphasis given on the laryngeal cavity. But it's very important to understand that there are some very interesting stark biological similarities. And if you want to extend the spectrum of understanding this anatomy, you should also actually include the uterus, because the cervical cancers also form a part of the same understanding of the extended spectrum of pre-malignant lesions. So it would be very interesting for especially the fellows to actually, before you go deeper into this subject, take a broader view and understand the interesting dimensions of the anatomy and biological similarities in some of these conditions. So if you look at oral cavity versus the larynx, which I'm going to be restricting to, you see the oral cavity, the typical areas of the mucosa where these pre-malignant lesions or potentially malignant lesions appear are having a lot of similarity with that of the vocal cord. Now, At the same time, if you see the lining of the mucosa, if you say majority of the oral cavity is lined by non-keratinizing squamous epithelium, whereas even the similarity, it's much similar to the vocal cords. Whereas here, what is interesting for you all to understand is why non-keratinizing epithelium. Now, if you look at the larynx per se, and if you study its anatomy, you see majority of the anatomy of the larynx, the respiratory epithelium is the sort of stratified columnar epithelium persists. But except for one small area, which is the vocal cord. Now, the vocal cord is the area where it is lined by non-keratinizing stratified squamous epithelium. I want each one of you all to sit and wonder, why is it that the nature provided this entire respiratory epithelium to all the areas except for the vocal cords? It has a very interesting reason. You see, in the body, keratinization is in evolution given typically for waterproofing. So when you want an area specifically to be waterproof, like your skin, then in that case, you are given a keratinizing stratified squamous epithelium, because the keratin crystals create such a nice maze which is interlocked so deeply that the water molecules cannot escape. Whereas wherever you need hydration, there the nature gives you non-keratinizing squamous epithelium. Now, the reason for that is respiratory epithelium is not a robust epithelium. It is not very strong. Its tensile strength is weak. So wherever you need to do a lot of work, like for example, in the oral cavity, you need to do a lot of chewing, a lot of mastication. In such kind of areas, you need robust epithelium. Similarly, in the vocal cord, when you have to do a lot of speech, you need to do a lot of phonation. At that areas, the nature gives you the squamous epithelium, because squamous epithelium is a robust epithelium. We call it the mechanical epithelium. It does a lot of hard work and is resistant to stress and strain. So nature provides you with the squamous epithelium. And in this specifically, non-keratinizing, because it needs hydration. Because if the nature would have provided this area with a keratinizing epithelium, you would see this area, the hoarse we would the voice we would have had is completely hoarse from the very beginning. So keratinization, if at all, if it starts to occur, is a representation of trauma to that area. And by nature, that area needs hydration. So one of the first things that happen here is when there is trauma, when there is loss of hydration, you start seeing keratinization as a very basic kind of a thing. And now this particular loss of hydration can happen because of mechanical stress, because of snoring, because of smoking. But the underlying part of this, the initiation is loss of the hydration, which leads to keratinizations and then the exposure to carcinogens. So with that, broadly, like I again emphasize to you, please have a broader outlook. I would want each one of you to study the epithelium transformation between oral cavity and the laryngeal cavity and even the uterus, to see what are the biological similarities there. How is it that these areas, although in different parts, behave so biologically similar that you get a uniform common denominator of an understanding in these subjects. Now, specifically, if you look at vocal cord leukoplakia, autopsy studies have shown that the laryngeal keratosis can be present in as high as 20% of the women, of the men, and 80% of whom were actually smokers. So this is a very common occurring, that undiagnosed leukoplakias or laryngeal keratosis can be present in as high as 1 in 5 of them. This is shown from autopsy studies. Now, the incidence of these clinically diagnosed laryngeal keratosis can be almost half of what is seen in keratosis. So which means almost half of them will not even go for a clinical diagnosis, but will live with this hoarseness, because this is a gradually increasing keratosis, which is typically seen in majority of the smokers or in vocal voice abuse over a period of time, over years. It's not a sudden occurrence. Whenever it is sudden, it typically gets to the notice of the clinician, but it's over a prolonged period of time, it generally gets less attention. Similarly, if you see, this compares to, if you see what its comparison is with local oral leukoplakia incidences, it's at about 16% and 8% respectively in the same population. Now, this is from Muller's study way back in the 80s, where they actually wanted to look at comparative figures in two homogeneous subgroups, so that we are able to give a head-to-head comparison of one single etiological agent, so that we have many common denominators. And I think such studies are lacking from India. And I think the focus that we should be looking at is to try and emulate such studies and see what are the similar patterns and build about such studies in our population, which can give some meaningful data from our own subsets, because our data is very much lacking in this area. Although we see a lot of these, there has been lack of systematic documentation in our subgroups. Now the majority of our discussion is because there has been some the more we understand the subject, the better it will help us augment our management. So why we do this? Because we want to identify and pinpoint the laryngeal mucosa, which is at greatest risk for containing or developing these neoplastic cells. And innocuous leukoplakic lesions or keratosis can be exempt from biopsy. So that's the whole discussion on why we need to understand potentially malignant lesions and discriminate them and kind of segregate them from the non-potential ones. Now, this is going to be a tricky one because in the oral cavity, we have the liberty of palpation, we have the liberty of a more direct visual examination, whereas that is not so easy in the laryngeal area. Now, very interestingly, when you broadly put the categories, I've always divided them into plasias and plakias. Now, the two important ones here, the plasias and plakias. Now, the plakias, the leukoplakia, the erythroplakia, the erythroleukoplakia are one subset of a category, and remember that this is clinical. So often if you see a pathologist writing leukoplakia, please note that that's not the right way to denote it, because leukoplakias are a clinical denotation of a particular visual description of appearance of a particular pathological lesion. So that is what is simply classified as a plasia, a plakia. Now the plasias are a subset in the plakias. So they are not present in all the plakias. So not all leukoplakias will have dysplasias, but the presence of dysplasia has a very special significance to understand leukoplakias. Now, the only way you can understand plasias is when you remove the leukoplakia or take a biopsy from it, a piece from it, and then study it under the microscope in histology to come and give a determinant note on does it have dysplasias or not. So it's very, very important for us to then, understand the spectrum of this disease. So here I have denoted a very a pictorial telling you about how transition of the epithelium occurs from normal epithelium towards hyperplasias, dysplasias, severe dysplasias, and then invasive carcinoma. This particular transition is what we have known for the last so many decades of our research. Now, what is interesting in this is now the recent classification of the WHO has switched back from the 4-tier system back to the 2-tier system. So earlier we had the very comprehensive 4-tier system, which said mild dysplasia, moderate dysplasia, severe dysplasia, and invasive carcinoma or carcinoma in situ. So we had 4 categories, the 4-tier system, which was way back in 2005. Now the 2017 system has gone back into the 2-tier system. Now the reasons for that are there are several reasons which you all need to know, but the most relevant reasons for this is lot of inter-observer variability and the lack of clinical correlation. Now, these are the two most important hallmark reasons why we have gone back towards the old classification systems. So it's very interesting that how we started from the first very old systems by Pinbog and others, and how we are slowly moving back towards this. So now we've come back into a very simple system, which is high grade versus low grade. Now, in high grade dysplasias, we call them as moderate dysplasias and severe dysplasias and carcinoma in situ. The category 2, 3, and 4 come under high grade, and low grade comes under the first one, which is the mild dysplasia, where the basal and the parabasal cells are normal with very minimal atypia. Now, the reason for that is when the basal cell and the parabasal cells are normal, it means that the germinal cells, the cells that are actively dividing, are normal. Hence, it's only a very superficial one in the topmost layers that you're seeing the disturbance of the, so which means it's a surface act. Now, this is very important, and I'm again going to come back to this particular reason. So please remember what I'm saying. Why this is important to understand the biology. I'll again be coming more in detail on the biological basis of this towards the end. But please remember, if the basal cell and the basal layers are normal, and if the topmost layers are only showing atypia, then this is relatively safer. And that's why it's low grade. And this is a histological system. Now, broadly, when in 2005, the WHO used totally 16 criteria, which we even now use today. Now, these 16 criteria are based on architectural changes and cytological changes. So, I have broadly enumerated all of these here. So, in 2005, it was a 7-9 criteria. Now it's a 8-8 criteria. So what you need to know is what are the structural changes and what are the architectural changes that you need to recognize to call a particular lesion dysplasia by a pathologist. So these are the histological features. Again, I'm not going to dig deeper into these, but for residents, fellows, it's very important that in addition to just reading the final line by the pathologist, where you're just reading the line saying what they've written in their conclusion, please do spend time reading these particular features and discussing them with your pathologist, because this will help you refine your knowledge, give you certainties, because a lot of the times in our clinical scenario, our clinicians, we often face second opinion reports or a third opinion reports, wherein we've just been sent an opinion from a pathologist whom you may not know, and you've just been forwarded this report to say they are saying that there is severe dysplasia, so what do you think, what should we do next? So I often go back and read the the fine print of the notes, where we actually look at architectural changes and cytological changes, and also discuss with the pathologist. This gives you more degree of certainty in your discussion. So if you look at the evolution of classifications, the evolution of classifications broadly has been accounted from way back in 1988 to to as early as the WHO's 1978 classifications, to the latest one where we say that the low grade one is mild dysplasia and moderate and severe are the high grade dysplasias. So there's been a whole lot of evolutions that have been done, and I urge all of you residents to go through each of these classification systems and understand the philosophy behind why each of these classification systems were posed so, but at least have a baseline understanding of the two important classification systems, the WHO 2005 and the 2017 system. Now, again, coming back to this question. So I earlier posed a question to you on what is the biological similarity or the histological similarity. Now the question comes, what is the pathological similarity? And I've posed two important lesions here. One is the area of the floor of the mouth and the ventral tongue. And this is the area of the leukoplakia or the vocal cord. Now, what are the pathological similarity in these two areas? Now, the pathological similarities one needs to understand here is there are two important things to know. And this is something that whenever you see oral cavity leukoplakic lesions, we broadly define them into high risk lesions and low risk lesions. It's very, very crucial for you to understand here that in the area of the vocal cords, no such anatomical description has been done. And this is again an area which I feel which a laryngologist should take a lead on to build maybe a multicentric study. And I don't know, maybe I'll urge Akshay to think over this, to say that there is a need for us to identify low risk and high risk sites within the vocal cord, within the larynx. Possibly of supraglottic sites being more high risk compared to the vocal fold lesions, and subset of the vocal fold lesion being more deeper analyzed. Today, with the advent of the narrowband imaging, NBIs, and other things, we will be in stronger positions to do so. And another very important area of deficiency here, which we have identified, is that unfortunately, like in a prevalent scenario in Asia, wherein the chewing tobacco habits are very prevalent, we have not been able to segregate the smoking related premalignant lesions from the chewing tobacco related premalignant lesions. And there is a need for us to segregate such studies to build up and understand habit correlations with leukoplakia and habit correlations with subsites. So is there a position for us to look at, because most of the Western data, which is on smokers data, is only depicting the vocal cord and laryngeal, the vocal cord subset of the laryngeal premalignant lesions, but has not well addressed the supraglottic lesions even in literature. So there needs to be more amount of studies that focus possibly through multi-centric approaches within the country, within Asian countries, to build up a consortium to address such kind of approaches to see whether are we in a position now to identify high-risk sites within the laryngeal subsites. So broadly, when we look at this entire gamut, we know that we have clinical, we have imaging, we have incisional biopsies, we have excisional biopsies, and we have some immunological studies. So these comprise the spectrum of the approaches we can have for understanding the pathological parts. So I'll broadly take you all to oral leukoplakias and what have we learned from it. So if you look at the pathological similarities, very interestingly, if you see, epithelial dysplasias in oral leukoplakia range from 5 to 25%. So which means only one among the 4 people may have a dysplasia in the white patch. So please remember this, that not all the white patches will have dysplasias. Now the second thing is that dysplasias seem to be more frequent in non-homogeneous lesions than in a homogeneous lesion. So typically, if you look at how do we clinically differentiate a homogeneous from a non-homogeneous, when you see a small particular area which looks like a blotting paper that is being placed on the table, which is translucent, you can call it homogeneous. Whereas if it's like a layer of multiple layers, like a carpet, which is rugged, then you call it non-homogeneous. Now, typically, the more the non-homogeneity, the higher the dysplastic features. And dysplasia is a histological expression of a genomic and molecular alteration or instability. That is why it's a hallmark. So what you need to understand from this, and especially our learning from oral leukoplakias, is that dysplasia is only seen in a small segment of 1 in 4 of the white patches that we encounter in this region. And that's why not all of them will have genomic instability. But having said that, if you see, 36% of the dysplasias progress to squamous cell carcinomas, and 16% of the oral leukoplakias without any dysplasia could still progress to carcinoma. So please note this, while the chances of a tumor progressing into cancer, that is a dysplastic lesion progressing into cancer, is twice as higher. That does not mean that if it does not have dysplasia, it doesn't go into cancer. And this is very important, especially when you communicate to the patient, because a lot of the times, you get a report from after the final excision from your pathologist saying that there is no dysplasia, and that should make you happy. But at the same time, it's very important for you to communicate to the patient that having no dysplasia does not mean that this lesion cannot progress to cancer. And this is a very important point. While the chances are half, the chances still exist and persist. So this is a very important thing that we've learned, and the most of these particular percentages still continue to be extrapolated to laryngeal cancers because of the biological similarity in the histological features that I elaborated to earlier. So if you see now in annual transformation rates in oral areas, it is about 38%. And the truth remains that no intervention has ever been useful to prevent oral squamous cell carcinomas developing into oral leukoplakias, and no treatment to prevent them. So surgery remains the mainstay of the work. So if you look at studies that have been published in this area, persons smoking more than 20 cigarettes daily have a 44% chance of developing keratosis, and even greater chance of 47% of them developing dysplastic vocal cord lesions. Whereas in light smokers, which is less than 10 cigarettes per day, they'll have a 12% chance of risk for dysplastic changes compared to 4% in non-smokers. So, this is in your clinical practice very evident that a small segment of them can actually come to you with lesions of the vocal cord, potentially malignant, which still without no habits at all, which possibly could be attributed to pollutions, vocal abuse, trauma, mouth breathing, and others. So please keep this in mind. While there's no mandatory requirement for people to have smokers, but there are other things which we need to be vigilant about. For example, we still don't have very strong data built up in our centers on mouth breathing, OSAs related, and oral leukoplakia and laryngeal leukoplakias. I think this is a very interesting area which needs to be collaborated with pulmonologists, and laryngologists to come together to understand what is the real denominator in people who are mouth breathers, who have vocal cord keratosis or potential malignant lesions. And such data set should be built up so that we get more prudent answers for the future. I told you all earlier that chewing tobacco habits have not been addressed in India, and this is a very interesting area because, see, the chewing tobacco we know has been a major implicant for supraglottic cancers, especially of the marginal zone. So the marginal zone is very, very similar to the cervical cancers in the uterus, wherein we get the transition between the squamous epithelium and the respiratory epithelium. So the marginal zone is typically the zone of the araepiglottic fold, where the food pipe and the air pipe convert into each other. So the larynx converts itself into the aerodigestive tract. And it is also the area where the pseudostratified columnar epithelium becomes the squamous epithelium. So always remember, in transition zone is the vulnerable zone, because that is the area of the most vulnerable genomic instability, because there is transition of epithelial going on. And in this particular mitotic interface of transitions, they are very vulnerable to the carcinogenic hit. And that is why they are more vulnerable to imbibe genetic changes and traumas in the genetic area without having proper repair mechanisms in the genetic system. That's why they get very easily converted into malignancies. Now in India, we see a whole range of cases on araepiglottic fold cancers. It's a very common thing that in India, in the laryngeal subset, araepiglottic fold subset is a very common one because of the prevalence of chewing tobacco. Now with this particular category, we've still not dealt with and have proper data on supraglottic related pre-malignant lesions. And I think that should be our future area of focus, to actually build databases in this region. Another thing what is interesting is whether or not stopping the smoking habit routinely returns the laryngeal mucosa into its normal histology is uncertain, because a lot of smokers ask you this question: sir, if I stop smoking, will I be normal? Now, I often explain to them that there is no certainty, but however, the chances reduced by almost 20 to as high as 50%. But it's very important for them to understand, because a lot of these smokers come to you with a pre-malignant lesion and say, I quit smoking 5 or 6 years back. So you need to understand that the genomic instability, the progression, the age-related results, the decreased repair mechanism all contribute to this. And many of these keratotic lesions are reversible if the etiological habits such as tobacco, alcohol, or voice abuse are eliminated. So at HCG, we have a very, Akshay spoke earlier about the speech therapy program, and integrated Dr. Shalini's team from the rehab side and all are working strongly towards prevention. We have the psycho-oncology team with Dr. Brinda. We have the prevention vertical with Dr. Vinod working together to look at de-addiction program as a very robust program, because I think the denominator to our success of surgeries done by Akshay and others would actually depend on the real work of also the integrated cooperation by the preventive team. Because if this person continues to smoke, I think you have defeated the entire purpose of all the good surgeries that we have done till date, you know. And occasional lesions disappearing without a change in smoking and other etiological habits is also well known. So this category is very, very important, because a lot of people ask me, so what if I don't do anything? So, you know, it's a very tricky situation for you to explain to your patient, what if you don't do anything, what will happen? So I think the most important thing for you to understand is homogeneous versus non-homogeneous, number one. Number two, after that is, if it is homogeneous, will it disappear on its own? Yes. There have been well documented reports of spontaneous regressions, but the chances of them are low. What you need to understand and explain to patients who are unwilling for surgical procedures is, give them a trial of antioxidants, but do please tell them that vigilant, close follow-up for at least 2 years is very, very crucial if they do not want to intervene. And also have a written documentation to tell them that you've explained to them of the chances of progression of these lesions. And that kind of makes it very important. So we typically, what we do is we give them a timetable, a 2-month timetable that is given to them and handed over to them with the month and date written, so that they are very clear that this is the timetable and they comply with it effectively. Now, what is the chances of malignant transformation in these lesions? Now, there is Weller's data that show that it is almost about 14% annual transformation rates over about 5.8 years. So this is broadly what we know of. And again, this particular thing you need to understand is 10% for mild lesions, and in the high risk category can be as high as 30%. Now, there again appears to be positive correlation between age at diagnosis and the laryngeal lesion severity. Again, like I told you earlier, the reason for that is that the more the age group, the poorer the genetic repair mechanism, and hence more vulnerability towards the hit of carcinogenesis, the impact of carcinogenesis, thus leading to more severity of these lesions. I'm just picking up this picture to show you a laser case of a leukoplekic patch, which was pre-malignant. Now, the main intent of the surgical procedure, why we are showing this particular video, broadly is to explain to you an important point. Now, when we take up a lesion such as this for laser, typically the policy followed at our center is that we first only explain to the patient that, look, this is a premalignant lesion. It looks like a non-homogeneous leukoplekic patch. We are going to go ahead and excise this complete lesion and send it for a frozen section analysis. Again, the use of frozen section analysis is very debatable, but I think Akshay can speak more on the technique. He's developed a very nice technique where he very meticulously kind of reorients the specimen. Most of this is again not to kind of get a confirmative diagnosis. We explain to the patient that there are limitations of frozen. But even if you don't send it for frozen, the importance needs to be explained to the patient about excising the lesion. And if you are able to give them a diagnosis of malignancy with a clear margin, then you're safe. Because this is a very tricky area, and naturally, globally, if you see, clinicians are divided on opinions in this area. So this is one of the classic topics for a panel debate, where you say, would you want to do a frozen section or not? If it's a pre-malignant lesion, what would you do? So broadly, what you need to understand is what we advise to the patient in such a scenario is we are going to excise the lesion. We are going to send it for a frozen section. If the frozen section says it's negative and that there's no malignancy, it is still not a foolproof method, but an initial thing to say for margins and for your diagnosis. If it says it's negative and the margins are clear, we clear the procedure there. If they say it's positive and this is a malignant lesion, then we redetermine and recheck with our pathologist for the margins, and then after that move further. So there are important implications, and I think there is a lot of overlap of these topics. I'm not going to go dwell into these parts, but I'm going to move into the aspects of the diagnosis. So today we are moving slowly towards genomics, proteomics, and metabolomics, and I'm going to come to the final aspects of my discussion. So now we've had a better understanding of what lies beneath the iceberg. So the tip of the iceberg is here, but the bottom of the iceberg is here. And this is where we need to have better understandings on how this genomic instability is occurring, and could we use predictive areas to actually predict and understand what is the level of this genomic instability. So in this, a very important thing that I wanted to communicate to you is the old theory was that the epithelium is seeming the origin of every disorder. Now what we know is it's not the epithelium, it's the stroma. So what a lot of emphasis has been moved into is to the stroma, that being the main culprit, saying that it is the stroma that actually changes first and that influences the epithelium. So it's not that epithelium is playing a role that is determinant of the progression of cancer. And if you remember one of my first slides, I said, if in the histology, the basal layer is affected, it means high grade. So please remember, the basal layers are out here. And the stromal communication with the basal layer seems to be the most important bone of contention today. So if you look at, if any of the attendees here are interested in pursuing further PhDs, research topics on this, the most interesting area to pursue would be to understand the cross communication between the basement membrane, the basal layer of cells, and the stroma. This is where most of the work is currently going on how does the communication occur between the glycophosphate layer of the basement membranes the basal layer of the cells in the epithelium and between the stroma. So there's a lot of dynamic interactions that are happening between these three components that holds the secret to understanding the carcinogenesis, the progression, the low to high grade, and all of these subjects. So this is a separate area of discussion which you can have it earlier. I'm just giving a simple depiction here. So here are, this is a squamous cell area which was showing infiltrating nests of pleomorphic squamous cells in the stroma with chronic inflammatory cells. Now what's interesting is in the same area on the opposite side, we were able to see in the same patient. So here why I'm showing this to you is this is the same patient on one side having cancer, on the other side having an epithelium where the stroma had already become desmoplastic, but the epithelium looked just keratotic. So when if you would have removed the epithelium in this case, the pathologist would have given you keratotic patch, but we went a little deeper and removed the deeper layer. And what they showed us in this pathological specimen was that although there was only low grade in the superficial layers, the below layer already had showed transformation, which means the stroma had already got converted through desmoplastic changes. So desmoplasia is a very, very key determinant, and we have ongoing studies at HCG right now that's clearly looking at the stromal layer, the desmoplastic changes, and how does that reflect and predict the progression of leukoplakias. We've also submitted our paper which got accepted in oral oncology, where we propose that the future of TNM stagings would also have to incorporate the iTNM staging, which is the immune TNM staging, that would actually give rise to answers beyond just the tumor stage, the node and the metastasis, to T denoting the T cells, N denoting the neutrophils, and M denoting the macrophages. Margins, again, I'm not going to touch into this, but I think the most of the quest today in our technology, and I'm going to touch the last part, which is the technological advances, is can we, without removing these particular lesions, predict which are those 13 to 15% of the lesions that are going to get converted to malignancies, and which are the 80% of them which won't get converted to malignancies. So the answer lies in these technologies. So if you look at industry today, we say industry is at 4.0, but health is only at 2.0. So the next generation of technologies that are going to define health 2.0 are going to be digital diagnostics, IoTs, ultra-fast scanners, wearables, blockchain, digital therapies, big data, nano health, AI, hackathons, system learning, and robotics. So I'm urging all of you, we need to embrace technology early. And these are some of the future ones that are going to create the new benchmarks for us. So we are going to be using technology through treatment, early detection, diagnostics, research, and prevention. And naturally, we've moving from visual examination through endoscopy, excisional biopsies, and tolerated blue, which is our current standard, to now looking at biotech fusions with fluorescence, infrared, Raman spectroscopy, and contact endoscopies. Now, with this entire thing, we've got these 10 interesting aspects which have already entered the market. Chemiluminescence, light-based detection systems like NBIs, tissue-based fluorescence imaging, tissue-based fluorescence spectroscopies, biomarker-based diagnosis, DNA analysis, laser capture detections, spectral cytopathologies, lab-on-chip diagnosis, and optical coherence tomographies. So what we are seeing in the next coming years is going to be a whole lot of interesting revolution on technologies. So I think I'll leave you all with these thoughts. Thank you very much. And if there's any questions, please do bounce it in. Thank you.
Thank you, sir, for the talk. Just a question. So clinically, what are your determinants to decide if a lesion, like you mentioned, 13% and the rest probably 80% would not transform itself? So what are the clinical indicators that you would look at to look at excluding those lesions or not?
So in vocal cord specifically, Anand, the main concern for us is regarding vocal cord lesions is the endoscopic findings and NBI now what we are adding to it. And I think, I'm not sure if NBI has already been dealt with, but I think a very important aspect in our armamentarium now to be used is NBIs. And I think it's an effective way to predict. With the NEES classification, there is a fair good certainty that we can predict which of these lesions are potentially malignant, aggressive, and which of these lesions are innocuous. So those could be two ways by which we could look at it.
Right. So probably that's it, sir. Is it advisable to perform any excision of a benign lesion with margins? I think you have touched upon it, but there was a question on this.
Yeah. No, I think the point is, when we say benign, we need to know benign is a separate category. Pre-malignant is a separate category, benign is a separate category. Now, if it's a benign lesion, you don't need to give a margin. What are the type of benign lesions can come there? You can have schwannomas there, you can have separate nodules there, you can have, so there are separate categories for benign lesions of the vocal cord, which is not the purview of my discussion here, but does not need a margin. If it's a pre-malignant lesion, a non-homogeneous leukoplakia or a homogeneous leukoplakia that warrants excision, in those cases, you need not give a margin, but it's important for you to clinically assess these pre-operatively with the endoscopy, with NBI, and intraoperatively under the microscope. Even today, there is a whole lot of group trying to do intraoperative NBIs. So there are ways to ascertain it. After that, we generally, as a rule, do not give the margin. I think Dr. Pratmesh and other Dr. Devendra and all earlier in their talks have told about palpatory techniques. They kind of palpate and move the epithelium over the lesion over the epithelium, and if it's fully mobile and it is not adherent to the lower underlying ligaments, they can know that. Again, in these cases, you can confidently avoid giving a margin. Like I told, we use frozen section, but frozen section is a completely debatable area, and most people may argue against it. So that's something, as an individual preference, you may want to choose or may not want to choose.
Right, sir. Thank you, sir. We'll move on to the next talk. The next talk is by Professor Cesar Piazza from Italy. We'll be talking on surgical and non-surgical determinants for optimizing results in TLM. Over to you, Professor Piazza. Professor Piazza, if you...
Okay, yes, I'm trying to share. No?
Yeah.
Do you see my screen?
Yes, we can.
I'm not, okay.
I think you can start the presentation.
Do you see my screen?
Yeah.
Okay.
We can. Yeah. Yeah, now we can. Good.
Okay, good. So thanks for the kind invitation to this virtual meeting. I will try to give my point of view on pre- and intraoperative determinants for optimizing results in transoral laser microsurgery. As you all know, the TLM is based on the fact that you are using a fixed corridor to reach your target lesion, and this not only from the visual point of view, but also from the surgical point of view. Your laser needs a straight line to reach and cut around the target. So in my view, one of the first determinants you have to assess before starting or thinking about TLM for a given patient is if the surgical corridor of that patient is at all okay for your maneuver and for your surgical procedure. To do this, in my residency program, I was used to evaluate the 4T, previous surgical or non-surgical treatment, the presence of trismus that could be related or not with treatment or previous traumas, the presence of long teeth, or the presence of an important kyphosis of the back of the patient. But this, apart from very extreme situation like this that perhaps may happen once in a life, was indeed rather insufficient, and in fact, in a number of intermediate situation or gray zone, a more subtle and detailed classification of the accessibility or not of the larynx of this patient was indeed most of time necessary. And taking inspiration from this paper, which is from an anesthetist, El Ganzouri, evaluating a number of different parameters of the upper aerodigestive tract of the patient to be orotracheally intubated, which is a quite similar problem in respect to the direct laryngoscopy we have to deal with. We developed in the 2014 this kind of predictive score of difficult or easy laryngeal exposure that we called the laryngo score. These variables, some of whom were mutuated from the paper from El Ganzouri, are usually scored in a very easy and quick way. There are 11 parameters that need 2-3 minutes to be properly evaluated in a given patient in the office without any special instruments. And these are the way you have to measure them. The interincisors gap in between the lower and upper teeth. It's good when it's more than 4 centimeters, suboptimal when less than that. The pteromental distance, which in the with the neck fully extended, you have to measure the distance in centimeter between the chin and the thyroid notch. If it's good if it's in between of 6.5 and 6 centimeters, and less suboptimal if it's less than 6 centimeters. Again, the dentition status is very important for exposure, for sure. In fact, it's quite easy exposure if the patient is a dentulous. Less than that if he has got a full dentition of the upper jaw, or sometimes impossible if he has got long and prominent teeth. But this is also something that you have to keep in mind, not only for laryngeal exposure issues, but also for medico-legal point of view. You have always to keep in mind that dislodgement, accidental dislodgement of teeth during laryngeal exposure is, in my experience, one of the most frequently observed complication of this kind of surgery. Can be just an aesthetic issue, but can be also a nightmare if you don't realize it and the teeth comes to the esophagus, or even worse into the trachea, and for example, after removal of the tube goes into the lower airway. So please always keep in mind this, to check the upper dentition of your patient before and after surgery in order to avoid this complication. Treatments may be related to surgery, traumas, radiation, and is always something that must be carefully evaluated, as well as macroglossia. The real true macroglossia represented in these pictures is rather rare. I would refer to a relative macroglossia, which means a normal tongue in a small mandible. So this is related to mandibular prognatism and micrognathia also. The normal tongue with small mandible, so the relative macroglossia, can be easily spotted if you look at the border of the tongue of your patient. If you see the mark of the teeth on the lower and part and border of the tongue, this means that the tongue is relatively big in comparison to the mandible, and this can be a problem during the laryngeal exposure. All other head and neck treatment in terms of radiation, traumas, open surgery, or spine surgery may be a problem in terms of internal distension of the larynx. Fibrosis of the pharynx and larynx may be a problem in during laryngeal exposure because the tissue are stiff and they cannot be dilated by your maneuver and your laryngoscope. And again, the rigidity of the neck into flexion extension may be a problem when dealing with the proper target exposure. And in fact, the degree of flexion extension of the neck may be easily quantified and must be easily quantified in the preoperative setting. It's very good, like in this girl, when it's more than 90 degrees. And you measure it quite easily, putting your hands below the head of this patient and asking him to maximally flex and maximally extend his head, and having a look to the more than 90, 80, 90 or less than 80 degree of movement. BMI is always important. Obviously, the more the BMI, the more difficult is the laryngeal exposure, for the same reasons already demonstrated before for the laryngeal internal distension and movement of soft tissues. And always have a strict cooperation with your anesthetist, since you can get from him or her a bunch of information about the easy or not with which he or she exposed the larynx of your patient during intubation. If we had a marvelous laryngeal visualization, this is a good sign. This means that you will probably will have a good laryngeal exposure also for your surgical purposes. And this can be easily appreciated by every anesthetist, just applying the modified Mallampati score that you have to teach to all your residents, also in surgical specialties, since this is the most reliable way you have to assess the oropharyngeal accessibility of a patient for your transoral maneuver. When you have assessed these things, you have a broad idea of a good or bad exposure of your patient, and you can start thinking about the more adequate instrumentation you will have to choose among your armamentarium. This is what I called a large bore laryngoscope, the Dido Ossoff, but obviously in every clinical setting you will have different instrumentation and different brands. However, this is what I call a good instrumentation for an easy laryngeal exposure. By contrast, when I fear or I have already tested a patient as a difficult laryngeal exposure, I have to shift from a large bore laryngoscope to a small bore one, like the Ollinger, which has got a much more specific shape for the difficult laryngeal exposure, especially with special reference to the anterior commissure. And then you can still adjust the position of your patient. If you have got an optimal situation, you can stay in the Boyce-Jackson position, which is a position of extension of the head on the neck at the occipital and atheroid joint, with the flexion of the neck on the thorax at the level of the lower cervical vertebrae. Please always remember that the most difficult is your laryngeal exposure, the more flexion you will need for your patient. So when you are in difficult situation, don't try to extend the head of your patient, but rather flex it. In this way, the larynx will come down toward the thorax, and your line of sight will be more easy and you will gain perhaps half a centimeter or 1 centimeter of visualization in your, for example, anterior commissure, which is typically the more difficult part of the larynx to be adequately assessed and operated on. So don't do the error, the mistake to extend the neck of your patient during difficult laryngeal exposure. First of all, because this can be associated to serious damage to the spine. And secondly, because you are getting in a more difficult situation. Try to follow my suggestion and always go in a flexion position. I mean flexion of the head on the neck and flexion of the neck on the thorax. And we will see some examples later. So on your left, you see what I mentioned before. This procedure was done by Klein Sasser under local anesthesia. So obviously these were easy laryngeal exposure, and this is an extension position. What I try not always to avoid, because it's dangerous and it's not helping you at all if you've got a difficult laryngeal exposure. What I mean is on your right, Boyce-Jackson position, which is perfect when the exposure is good. And I will show you later a flexion position when the exposure is bad or suboptimal. What I want to underline here is that the true suspension laryngoscopy system, as described by Klein Sasser, is nothing having to deal with a chest suspension table. It's a true suspension system in which you have to suspend the larynx of your patient through a mechanical arm like this, commercialized, for example, by the Boston Medical University, but there are many other brands and many other systems like this. The most important thing is to have a true vertical suspension system, not a chest based or a chest table based approach, which is not a suspension, is a supporting system, which is very different. In a supporting system, you can do a good and laryngoscopy and even a biopsy if you want, but for operating, you need to have a very solid situation in which the suspension allows you to see to internal distended larynx and see everything you need into the larynx. Because the target, I always stress it, is the anterior commissure visualization that you can get in a very easy way with a large bore laryngoscope without external laryngeal counterpressure in the Boyce-Jackson position. And this is the ideal situation, class 0. Class 1, you need an external laryngeal counterpressure. In the class 2, you need an external laryngeal counterpressure, and you need to change the position of your patient in a neck flexion position, but you're still able to use a large bore laryngoscope. In the class 3, the situation becomes much more difficult. This is not for a beginner. You need to shift to a small bore laryngoscope, and you must use an external laryngeal counterpressure and a neck flexion position. While in the class 4 situation, you're not able to visualize anything of your larynx, and so you cannot operate at all with any kind of laryngoscope, with any kind of maneuver, and so on. So just to be more practical, this is the ideal situation, class 0, large bore laryngoscope, full visualization of anterior commissure without external laryngeal counterpressure in the Boyce-Jackson position. You can see in the right picture, the resident is just looking at the show with the hands in his pockets. I don't need his help. And in fact, I'm very satisfied and very happy with this patient. In the class 1, you still need a large bore laryngoscope, but this is the situation without external laryngeal counterpressure. And for full visualizing the anterior commissure, you need that the help of the resident counterpressing from the external surface of the larynx, the anterior commissure, in order to be able to operate properly on that. And in fact, you see, I'm pressing on the larynx, and the resident is ready to substitute my hands whenever I will need it for operating with 2 hands on the larynx of this patient, but still is in the Boyce-Jackson position. The class 2, I can still use the large bore laryngoscope. I need the help of the resident, but I need also to furtherly flex the position of the neck. And in fact, if you see the arm of the suspension system is no more in a vertical position, is slightly pushed forward. This means that the position of the neck of the patient is flexed, and then sometimes I need to put it in anti-Trendelenburg in order to have a comfortable visualization through the microscope. And this is the awful condition. With the large bore laryngoscope, I cannot see properly the anterior commissure, so I need to shift to a small bore laryngoscope, and again to apply every trick I can, external laryngeal contrapression, flexion position, and so on, in order to get the proper exposure of the larynx. But please remember, this is a very difficult scenario in which you can treat and properly remove small tumors, but not for sure larger lesions or lesion positioned in a difficult area of the larynx, like for example, anterior commissure, or the deep part of the ventricle, and so on. And this is not a surgery for residents, because this can be something quite cumbersome. Well, this is not a condition for anyone. You don't need to go on with your surgery here. You cannot properly visualize anything. You can do just a biopsy. You can do just an endoscopy, or a benign surgery if you need it, but you cannot properly resect cancer in this situation, because you don't see much more than the vocal process of both vocal folds. So you are not in the position to remove any cancer from this larynx. So refer this patient to radiation therapist, or if this is not possible, or the patient decline radiotherapy, think about open partial laryngectomy if you need to remove a cancer. So applying systematically the laryngo score, you may have some kind of prediction of your difficulty in laryngeal exposure. If the score is less than 6, you will have nearly always a very good laryngeal exposure. If the score is in between 6 and 9, you will have half and half, a situation with good exposure in about 54% of patients. Good exposure for me means always be able to use a large bore laryngoscope, not a small bore one. That's a suboptimal exposure, or even difficult exposure. If the laryngo score is more than 9, please be prepared to have a small bore laryngoscope to pass a very difficult surgery, or even prepare your patient to an alternative option, because TLM could be unfeasible. These, in our opinion, were the most important factors affecting the prediction of laryngeal exposure. So after 2014, we tried to eliminate the more subjective elements of this laryngo score, trying to develop a so-called mini laryngo score. So an easiest tool that focusing only on these the most important 4 parameters: interincisor gap, thyromental distance, upper jaw dental status, and upper jaw, sorry, these 3 parameters, and upper jaw dental status, distinguishing edentulous, partially edentulous, normal teeth, and prominent teeth, allowed us to give a score from 0 to 4, in which 0 was given to the optimal condition, good interincisor gap, more than 4 centimeters, good thyromental distance, more in between 6 and 6.5 centimeters, and good upper jaw situation, I mean edentulous or partially edentulous patients. These are the very easy situation that allows you to score a mini laryngo score as 0. This is associated to a nearly always very good laryngeal exposure. If the mini laryngo score is 1, I mean 1 out of 3 of these parameters is suboptimal, you have got again a good laryngeal exposure in 85% of patients. When you have got a mini laryngo score of 2, you have got again rather about half or more than half of patients of good laryngeal exposure. But when mini laryngo score is 3 or 4, again, you are in more than 4 patients out of 5 of your series in a suboptimal laryngeal exposure. Laryngeal exposure has got a very strict connection with the quality of your surgery in terms of positivity or safety of surgical margin. And in fact, and when you look this retrospective analysis on our own data, we saw that when patient had a very good laryngeal exposure, I mean class 0 to 1, which is fortunately enough most frequently than not, 74% of patients, the rate of positive margin was about 1 out of 5, and I would say 1 out of 10 of problematic deep positive margin that needed a second look, surgical resection, or some kind of further treatment, like for example, open partial laryngectomy or radiation therapy in order to get rid of that positivity. By contrast, when you were in a very difficult situation, I mean class 2 and 3, which is encountered in about 1/4 of our patients, the rate of positive margin raised to about half of our cases. And deep margin in particular, which are the most dangerous, were about 1 out of 5 of these positive situations. So please always keep in mind that these are not academics, these are very practical issues that must be evaluated in order to choose the most appropriate therapeutic weapon for your patients. And in this sense, what Professor Rifat previously mentioned, the value of a multidisciplinary approach is in these details. If you have a doubt that your patient will have a suboptimal laryngeal exposure and you have not sufficient experience to deal with that, because or the tumor is large enough to make you worried about completeness of your surgical resection, please do not hesitate to seek for alternative treatment, because perhaps a TLM is not a good idea for your patient. Then there are specific difficult scenarios in which you have to look properly at the larynx of your patient, and the laryngeal exposure is not a problem indeed, but the tumor location and tumor staging is a problem. For example, these are all small T1 or very superficial T2 extending from the glottis to the supraglottis, and theoretically on the chart they could be perfectly resectable by laser. The problem is that they are centered on the posterior third of the vocal fold. So with the standard approach through a transoral laser surgery with the transoral orotracheal intubation, the most part of the tumor will be masqueraded by the presence of the tube. So in this situation, you must be prepared either to shift at half of your surgery from the orotracheal intubation to a jet ventilation, like as you can see in the lower picture. in this patient, we already resected the anterior half of the tumor in a classic way, while to deal with the posterior half of the tumor, we switched the orotracheal intubation to a small catheter jet ventilation in order to get rid of the posterior part of the tumor. Otherwise, if you are not able to use jet ventilation in your OR, at this point, you have to change your laryngeal exposure, push the tube in front of the anterior anterior commissure, positioning your laryngoscope in between the tube anteriorly and the posterior commissure posteriorly, in order to have a safe exposure of the larynx. This is not always a very easy maneuver. You may need a very small tube, 5 or even 4 sometimes, and a good very good laryngeal exposure, because at that point your line of sight can be suboptimal and a little bit masqueraded by the, in this case, right arytenoid. But however, in any case, you must be prepared in these posterior tumors to deal with a difficult or tricky laryngeal exposure that may require some adjunctive skills. Like also when you are dealing with large and difficult tumors, like for example, those involving the lateral paraglottic space going in a transglottic fashion into the upper or lower paraglottic space, or those with an anterior transcommissural extension. I mean, not T1B involving just the anterior commissure, but tumors spreading upwards into the petiolus of the epiglottis or downward into the subglottis subcommissural area. These tumors are difficult TLM indication and must be embraced only when you have got a very good laryngeal exposure. Then there are tumors that, in my opinion, are absolute contraindication to a TLM approach with radical intent, provided a good or a fantastic laryngeal exposure, whatever. This is not a matter of experience. This is not a matter of laryngeal exposure. This is a matter perhaps of oncologic indications. For example, when you have got a massive T3 with arytenoid fixation, full invasion and full involvement of the entire paraglottic space from the upper to the lower part of the larynx, from the anterior to the posterior half of the laryngeal compartment, that, in my opinion, is not an indication for TLM. Even because when you're dealing with tumors in the cricothyroarytenoid space, like those already mentioned, you are not sure 100% before you have done a proper resection that the tumor is not indeed a T4, instead a small T3 is, instead a big T3 is already a small T4. I mean a tumor that has already progressed outward the larynx through the cricothyroid space. And at the present state of the art, I do not know any imaging technique that allows you to detect, to spot this single small extralaryngeal extension of the tumor in the preoperative setting, giving you the right to try with a reasonable certainty of success your transoral resection in a situation like this. Thank you for your attention.
Thank you, Professor Piazza. Nice talk. We have a couple of questions. So one related to the laryngoscope itself, the variables that are used. Does epiglottis figure in it, the shape of the epiglottis? Does it have any impact on the laryngeal explosion?
Well, no, I would say this is mostly a problem from the anesthesiologist, which that usually do not charge the epiglottis with their instrumentation for getting intubation. So if they are facing with an omega-shaped or rigid or contrary floppy epiglottis, they may have problem in having a smooth intubation. For the laryngologist, instead, usually this is not a problem, because for glottic surgery, we always charge the epiglottis with our laryngoscope. And even in case of supraglottic cancer, we don't charge, obviously, the epiglottis. We keep it in fully view, because we need to resect entirely of part of it. But this is, again, more a problem for the anesthesiologist that must intubate the patient. For our aims, the epiglottis is usually not an issue.
Another question which probably I noticed on your presentation, the endotracheal tube that is used is quite different from what is regularly used, routinely used. So is it some special variant or any particular modification to the endotracheal tube that you use here for your procedure?
Well, unfortunately, in the past I was using a kind of very good tube that now are no more on the market. So I recently had to shift to at least other two kind of tubes that are, in my view, suboptimal. So there is a space for, I think, in the market now for making a better research on this in this field on laser safe tube that must be in their ideal fabrication with the best ratio between external and internal diameters, obviously done by materials that are not at risk of fire, and with a double cuff, the external of which should be always inflated with water, and in my experience is usually to color this water with methylene blue, so that when you for mistake you make a hole in the external cuff, you suddenly see the blue in your field, surgical field, and you don't risk to go on and make a hole even in the second inner cuff, then causing a serious risk of inhalation of your patient and problem with ventilation and prosecution of your general anesthesia.
Another question, in cases like the class 2 or 3, where the exposure becomes difficult, particularly the anterior commissure area, there would be possibly an increased chance of positive margins or closed margins there. So do you look at redoing the procedure, again, reorienting and repositioning before you achieve a clear margin?
Yes, yes. This is obviously always the aim of the surgery. But the point I would like to stress is that any way you do it, any way you experience you have with that, and for what you may be particularly skilled, you always risk a higher percentage of positive margin. Sometimes you can prevent this by doing frozen section, but again, keep in mind that frozen section are always, I would say, a suboptimal way of be sure of your safe margin. I mean, the safety of your margin is usually in your eye, in your technique, and in your adequate microscopic magnification. When you are dealing with frozen section and you are relying on that too much, I think you are in trouble, since the I mean, the affordability of the frozen section in this kind of surgery is rather low, because you send to the pathologist very small pieces of tissues. You can have some part of them with thermal damages. And honestly, I don't rely too much on them. Well, when I'm desperate, obviously I do that, but it's not my first defense against positive margins.
So, when would you advise, adjuvant treatment after a transoral laser microsurgery?
Well, I use it quite rarely, and honestly, I always see it as a mistake. There is I plan it quite rarely, and a classic indication for me of B-model treatment, TLM plus adjuvant radiation, not as a surprise, but as an intentional planned treatment, is when I'm dealing with borderline tumors in patients who are not amenable to, for example, open partial laryngectomy or non-surgical organ preservation strategies. I mean, bulky T3, for example, that in a 45-year-old guy I would treat for sure by open partial laryngectomy or chemoradiation. In an 85-year-old guy, I do a TLM, and then I do postoperative radiation, because I'm sure that he will not be able to tolerate organ preservation in another way, and I don't want to make a total laryngectomy, or the patient push strongly not to have a total laryngectomy. So I try to keep the safest way by doing an extended TLM procedure like that I will show you later in the video, and if I need postoperative radiation, because, for example, I read the positive margin at the level of the thyroid cartilage. The thyroid cartilage was okay, but I cannot demonstrate it, and I cannot get an extra safe surgical margin by TLM. My safe surgical margin would be the resection of the thyroid cartilage, but I don't believe it's a good procedure done by TLM. So in that case, I add on the top of my extended resection radiation therapy. This is quite rare, however.
Okay. Thank you so much, Professor Piazza. We now move on to the next talk. So the next talk is Beyond Conventional Boundaries, Lessons to Learn in TLM by Professor Prathamesh Pai from Tata Memorial Center. So your presentation is up. Yes.
Hello, can you hear me now?
Yes, sir. Yes, sir. We can.
Can you see the presentation?
Yes, sir.
Hello.
Yes, sir. We can see the presentation as well, sir.
Good afternoon, everybody, and thank you, Akshay, for the invitation. We have friends across from Italy to Australia, and it's a good modality of transferring information across. We have heard very good talks from the afternoon, and my session is to talk to you about something beyond conventional boundaries. So I was really wondering what I should be talking to you, but then I realized that the main objective of transoral laser surgery is to achieve good margins. And as Piazza very elegantly showed, what exactly goes towards achieving those. So I thought I should focus a little on the basics, the ergonomics, the positioning, suspension, laryngeal exposure, the submucosal infiltration, the types of laryngoscopes, and a little bit about excision biopsy. Because as when I began doing laser surgery, these were things that really troubled me and I didn't get good information on. Now, when you look at the ergonomics in transoral laser surgery, you need to realize that this may appear very difficult, but believe me, this person actually got a better look into the larynx, because you can see it was a complete flexion position, as Cesare showed so elegantly. So we need to work on achieving this. But while doing this exposure, you need to realize that you might end up with work-related musculoskeletal disorders, particularly our neck, our back, because we are going to be trying to visualize into this larynx, and trying to do that, you might endanger your neck and back. So you need to look into the various ergonomics that actually help you plan out a good transoral laser surgery. And what you need to focus is a good chair and the use of supports. So this one study I came across, which very beautifully evaluated what type of supports the surgeon requires and whether it can be achieved with an articulated arm, a Mayo stand, or is it good enough to do without any supports. So when they analyze that the minimum angulation of the surgeon's head is required to protect neck and back, and we need to support the upper extremity to reduce shoulder movements to improve the action or when we are operating. So we need to see that our neck flexion, the surgeon's neck flexion, should not be more than 20 to 40 degrees for more than 1 hour. Beyond this, you can actually cause problems to your neck, and you also reduce the action of your muscles. So what is the best is an articulated arm support. So your chair should have an articulated arm support. I'll show you in a few slides. Again, we rarely realize this, but the L5-S1 disc space is most occupationally injured when we are doing these surgeries. And again, if you're doing an unsupported surgery, that means you're not supporting your arms either with a Mayo stand or an articulated arm, you actually increase the compression force 4 times on your lower disc space. So you don't realize it, but you might slowly damage your spine. Now, when you look at the torque and the force distribution, you realize that when you're using no supports, you're actually having a lot of overaction and increase the torque. But between a chair supported position and a Mayo stand, there's very little difference. So please make it a point to use the supports. Again, we have now a lot of fancy microscopes with adjustable eyepieces, and we tend to place it upside down or down. When you place it up, you tend to cause more of a neck extension, and the more neck extension causes a problem, and the positioning of your table again changes. This is the kind of chair that you require with the arm supports. And again, Piazza mentioned about the reverse Trendelenburg. So if you position the patient carefully, you will be able to reduce the amount of extension that you actually require. So the patient's bed should be in flexion, and along with that, you need to do a reverse Trendelenburg so that you get accurate positioning onto your larynx. Now, position of the patient's head is very important, and Piazza alluded to that briefly. So normally we do a neck break. We have all these new tables where you can break the neck. Some of us use an extension, and some of us use an hyperextension using a shoulder bolster. Now, the anesthetists have been at it, and they have been evaluating this since long, and they realized that there are 3 axes. One is the oral axis, one is the pharyngeal axis, and the third is the laryngeal axis. All the 3 should actually coincide in order to give you a very good visualization into this. So ideally, you need to have a 15 degree for the upper cervical flexion and a 35 degrees of the lower cervical extension. And this seems to give the best visualization of the airway. So when you look at these 4 diagrams, they actually are MRI of the patients who were taken with and without neck support, with and without flexion and extension. And when you can see this with the proper support below, flexing the neck and extending here at the atlantoaxial joint, the classic sniffing position gives you the best result because it reduces your air space posteriorly in order to bring the larynx into visualization. Now, we come across a lot of obese patients, and the Cormack-Lehane laryngoscopic view will actually tell us and guide us along with the Mallampati score about the laryngeal exposure. And Cesare's group has brought about the laryngo score, which we have used now with very good results. Now, if you have a patient like this, what is important to realize is that the mastoid to the sternum position has to change. So when you give a support from below and your mastoid to the sternum position comes in line, you will get your best exposure of the larynx. So if you have an obese patient, this is the kind of exposure you need to do and with adequate support. So the glottic opening score with the head flat versus a 25-degree backup position, there was a 66% improvement. So you can achieve this by either giving supports from below or doing a ramp up by breaking the table upwards. Again, the superior view, when you actually look at the amount of pillows and the thickness of pillows, with 9-centimeter pillow, you had the best view. Another thing that we need to look at is the neck length. The shorter necks had a better view when you had thinner pillows. So if you have a short neck but a normal BMI patient, you should use a 3 or 6 centimeter elevation. How do you suspend makes a big difference. Time and again, we have seen that we were taught during residency to suspend the larynx over the chest, and it was called the chest suspension. Piazza showed the newer forms of suspension, and this is what we use at our hospital. We use the Karl Stoll's chest suspension, which is attached actually on the table. It's a kind of a plate on which your suspender will affix. What is important to realize is that this moves also. So this actual movement alongside the sideways gives you ability to change the position of the larynx. Sometimes you have awkward teeth, sometimes you have a rotated larynx. And if you have this ability to move the suspension from side to side, you can actually get a better exposure. Now, this is the gallows suspension, which is by the Boston Medical Associates. And this actually gives you a very good exposure without having any compression on the chest wall. Now, you can imagine what we were talking about. And this was propounded by Steven Zeitels way back in the early 90s, the flexion position, where the surgeon would hold on to the patient's head and achieve this kind of a vision. So you can see that with the laryngoscope, you're seeing straight down into the larynx with a flexion position. Now, having said that, I need to talk about how do you manipulate the larynx. Now, this is the kind of, once a laryngoscope enters the glottis, this is the epiglottis, and this is the larynx, we are trained to go as far inside as possible to get a better view of the anterior commissure. But look at the hyoid and look at the thyroid cartilage. The further you go below, the less you'll be able to manipulate the larynx. As Cesare showed beautifully in the class 2 and 3, you will require some amount of manipulation. So please do not insert your laryngoscope way beyond. Leave it at the level just at the level of the hyoid, because then you will get a external manipulation of the thyroid. This is not something that we recommend using a single kind of a fixation onto the table. You should have an assistant who can then manipulate this larynx, the thyroid cartilage over the cricoid in order to give you an exposure. So this is not a fixed exposure. You need a dynamic exposure. As you're operating, you need to have some movement of the thyroid so that you get good exposure of the larynx. Coming to submucosal infiltration, Akshay talked about it. So did Professor Cesare, and we realized that all that we are trying to do is have a good exposure. And when we looked at how the multidisciplinary team, Professor Ifad, we use this information to plan out whether you'll offer radiation or you'll offer TLM. Now, Zeitels showed how the various layers of the vocal fold can respond to the submucosal infiltration. So you can use a laryngeal needle, which is a 25 gauge needle, and you can do a submucosal infiltration. If the mucosa is not adherent to the ligament, it rises completely. On the other hand, if it is fixed, you will have something called as the donut effect. So you have the fluid rising all around, but not where it is attached to the ligament. Now, we do not have the 25 gauge laryngeal needle available freely. And what we practice is using a regular butterfly needle. We use a 25 gauge needle. We cut off these two ends of the butterfly, and we are able to achieve the same. So we can use a crocodile forceps and use the butterfly needle and achieve the same kind of a thing for a submucosal infiltration. So these are just some few practical tips that we can use in your day-to-day practice. There has been a paper about air infiltration and transillumination. I haven't practiced this, but I find it very interesting that you might be able to infiltrate air into the submucosal space, create the same kind of space that you really require to remove the uninvolved tissue. And in cases where you want to remove cysts and polyps, you might be actually able to preserve a lot of mucosa. Coming to the laryngoscopes, I think Cesare has spoken on it at length, but I just want to focus on the types available. You have the Jackson and the Hollinger type of scopes. You have the Dero laryngoscope, which is the workhorse. What we use is a Klein-Saucer laryngoscope that has a non-reflecting coating, which is very good for laser resections. And for supraglottic and for piriform sinus cancers, we use the Vida laryngoscope, which actually provides a very good, excellent exposure. You also get now the Steiner type of laryngoscopes, which give you a flange on either side, which can actually prevent the tongue from coming in between the two blades once you distend the laryngoscope. So this is a kind of laryngoscopes that are available of various types, and you can use the most appropriate one, as Cesare said, for class 2 and 3, and going on to class 4, you'll require narrow ones, or the routine laryngeal exposures. You can use either the anterior commissure scopes or the regular Klein-Saucer scopes. There has always been a debate about excision biopsy. I feel the very thought that you are doing an excision and a biopsy is oxymoron. When you say excision, you're removing the whole thing. When you're saying a biopsy, you're trying to understand the histology. So you need to understand that removal of tissue alters the vocal fold dynamics. And all our efforts are towards preserving voice and achieving an oncologic safety. As Professor Rifat said, you should not grab. So the very fact that you're punching out tissue, it shreds the tissue. And that's where the term stripping came from. So when we were training, we were told vocal cord stripping is the procedure today. And that's truly what it was, just yank it off from the muscle. But what we have to do is very precise surgery. As Akshay said, that he will be using the precise super pulse mode in a continuous manner or in a repeat manner with specially designed scanner mode can actually remove layer by layer without disrupt the adjacent layers. And if you do an excision biopsy, what happens is you're not achieving that end result of a negative margin. So if you have a lesion like this, or you have a lesion in the mid-cord, what prevents you from taking a margin? When we analyze the pathologies of a biopsy, excision biopsy, we realize that most biopsies are curative because the lesions are so small that, and your biopsy forceps are so huge that you would have removed all the tumor, and the actual surgeon who's going to follow you, or if you're not the actual surgeon who's going to treat the patient for cure, will not know where to resect. And revision resections rarely show any tumor. So you have removed more than required, you have damaged the patient's voice, and the patient has not achieved a good cure. Many times we get patients, almost 40% of our patients have undergone this sort of resection, and we feel that we now have a missed target. We really do not know where to go ahead and remove what, if at all, we need to remove. So today we have the technology, we have narrowband imaging. You can be sure whether you're dealing with a benign or a malignant tumor. Even if you're dealing with a benign tumor, by taking off 1 millimeter of mucosa, you're not going to harm the patient. In fact, Professor Peretti and Cesario have shown in their study of over 500 cases that when you do a type 1 or a type 2, that is a submucosal or a subligamental resection, your voice outcomes are the same. You get very good voice quality. So we should not practice an biopsy. If at all you have lesions which is amenable to a complete resection, and you have not discussed about the histology, you have to tell the patient that you will be able to do a safe resection. So the concerns in our country are putting up the patient again for another surgery after a diagnostic procedure. So I can well understand the constraints that we are having. But please, if you're going ahead with an excision, do a proper resection with 1 millimeter margin, and you will be assured of good voice quality. Thank you very much for a very patient listening.
Thank you, sir. That was a nice and interesting talk. I had a question. Now you're working in an Apex referral center, and it wouldn't be uncommon that you would get a case wherein has undergone a biopsy outside, by a trained surgeon probably, and it turns out to be, high risk or probably malignant. In that case, what are your cues that you take from the pathology report to decide that do you take him up for relook, or do you go ahead with an excision? What helps you decide?
So this is the same kind of scenario that I had told you we come across, that you have a patient who has been operated at another center, and once they get a report of a malignancy, they would refer it to our center. So now when you have seen this patient, 2 weeks would have gone by, and you are seeing a patient without any lesion on the vocal cord. So today we would use narrowband imaging to discern whether there's any surrounding area which looks abnormal. To me, this is a classic case wherein you should wait. You should observe how the lesion is behaving, because if you go ahead and resect it, you will damage more. You're not going to harm the patient by waiting. I would normally wait for 2 to 6 weeks, wait for that edema to settle down, wait for the patient's voice, see how it is progressing. If the pathologist is going to tell me it's a squamous cell cancer, he may tell me it's a poorly differentiated cancer. But if he's not able to tell me about the margins, I do not know whether I should proceed with a re-resection or radiation. So in that case, I will observe the patient, I will counsel the patient that you will not be harmed by waiting, and then relook it at about 4 to 6 weeks.
So you did speak about getting the exposure right. You mentioned certain techniques that can be used to improve exposure. But often you would have situations, despite this, the situation looks bad, or probably the ET tube coming in, the posteriorly based lesions. Do you suggest doing a tracheostomy, prior to before? Because some people have reservations saying that you should not.
So Akshay did show that in certain cases they would do a tracheostomy. So I have not had that opportunity in the last 10, 15 years of having to do a tracheostomy. So we would do an apneic technique and try and visualize it. If there is a complete visualization, we would then proceed under apnea. Cesare talked about a case wherein you would have a posterior based lesion, in which case, if you have a 5 millimeter tube or a 5.5 millimeter tube, you would necessarily, once you're done an anterior resection, reposition your scope by pushing the tube anteriorly and then complete the resection posteriorly. So these are the 2-3 ways, either using a jet ventilation or using a apneic technique, I would complete the procedure.
Thank you, sir. We would now proceed to the surgical techniques, how I do it, tips and tricks. Okay, we have surgical videos. We have a video on extended cordectomy, type 4 and type 6 cordectomies by Professor Cesar Piazza.
Thank you very much.
Before we, after this, we would be concluding, and we would be having the closing comments from the experts and the speakers. Also, any questions which were probably unanswered, or any new questions that have come up, if you could, put it up on the chat box, we'll take it at the end of the session.
Hello?
Yeah.
Must I present my videos before the last presentation?
Yeah, so we don't have the last presentation today, so we directly go ahead.
Okay. Okay, okay. Okay. So do you see it?
Not it seeing your shared screen.
So I share, and yeah, you should see it. No?
No. So.
Okay. Okay.
Yeah.
Yeah.
Yeah. Now we can.
Okay. Perfect. It's okay?
Yeah.
Okay, thanks. So I just a quick view of two kinds of extended cordectomies. And just first of all, a quick reminder of what extended cordectomy means. According to the European Laryngological Society, that published two classification, one in 2000 and one in a revision in 2007, adding the type 6 cordectomy. The extended cordectomies are considered the type 5 and 6. Type 5 may be extended in different ways. I mean, the type 5A is extended along the glottic plane from one vocal fold through the anterior commissure and to the contralateral vocal fold. The type 5B is the extension posteriorly to the arytenoid cartilage. The type 5C is extension vertically to the ventricle and false vocal fold, while the type 5D is extension subglottically to the subglottic area, conus elasticus, part of the cricoid cartilage, and so on. The type 6 is what we call anterior partial laryngectomy. It's the excision of both anterior half of the false vocal fold, petiolus and of the epiglottis, both anterior half of the vocal folds, and part of the subglottic mucosa, including or not the cricothyroid membrane or part of the cricoid or tracheal mucosa. All of this kind of resection can be differently associated in each other. And in fact, I will show you not a pure type 5A or a pure type 5B, which are exceedingly rare in my experience. I will show you a combination, for example, of a type 5A and B or a type 5A and C, because as usual in transoral laser microsurgery, the most important pros is that you can modulate your resection according to the specific extension of the tumor at the level of the subsides of the larynx you have to treat. So there is no, fixed rules in order, this classification must be used in a very elastic way, and as I will show you, can be of great help in defining which subsides have been removed or not. Then there are another concept that I want to stress here, the en bloc versus multi-block or piecemeal technique. This is not a problem of nomenclature. This is a problem of surgical technique based on the specific characteristic, again, of laryngeal exposure of a given patient and possibility for that given tumor to get adequate unblock one piece removal if you can, as in this case, control adequately the inferior border of the tumor. This is always my first choice because this is always easier for your pathologist. By contrast, if you don't have a complete three-dimensional control of the tumor, please do not hesitate to perform a multi-block technique like that I will show you later in the second video. So this is a T2, small T3 for anterior paraglottic space invasion, involving the left vocal fold and the ventricular band and the ventricular sac that can be resected safely by a type 5A and C extended cordectomy with an en bloc approach, because this is not a bulky tumor and you can safely control its subglottic extension. When I'm not able to do this, I have to shift to a piecemeal resection, as I will show you later. But look, moving laterally the left vocal fold, you can dominate in a perfect way a free margin in the subglottis, so you can perform it in an unblock fashion with a very easy approach that will not last more than 40-45 minutes and will spare time also to your pathologist, because he will be able to orientate perfectly the tumor in the 3D, giving your margins in a perfect way. So you see, This was on the horizontal plane a type 5A chordectomy, since we crossed the midline, and we removed also the anterior third of the right vocal fold. In the depth, we left part of the lateral vocal muscle, and inferiorly, we got a safe margin at the level of the subglottis, completely removing also the false vocal fold, and most importantly, reaching the thyroid cartilage, as you can see on the left of the screen, at the level just above the vocal fold. That was the most difficult and crucial part of the procedure, since this tumor was a transglottic tumor reaching the paraglottic space at the level of the ventricle and false vocal fold. So it was not necessary at all to remove the entire vocal fold, but it was necessary to reach the thyroid cartilage at the level of the ventricle and false vocal fold. Again, when you are not able to control the inferior margin of the tumor, like in this slide that you can see on the left of your screen, then you have to cut through the tumor, as already described by Steiner in his wonderful textbook that I suggest to every resident and young surgeon approaching this kind of technique. And you will see that it allows you to get an easier surgical resection, but a much more difficult work for your pathologist, in which the cooperation in between you and them will be for sure essential in getting a proper orientation of all surgical margins and all the surgical specimen. So this was a case in which I approached this tumor by a multi-block technique. This was a T2B glottic cancer with the vocal fold hypomobility. The tumor was extended on both sides of the larynx, but as you can see here, it was not infiltrating the false vocal fold nor the ventricle, that will be resected just for exposure purposes. As I mentioned in the first lecture, to resect properly this kind of tumor, you have to get a very good exposure. This patient had a good laryngoscore, but on the top of this, I wanted to add a full supraglottic resection of both vocal folds and false vocal folds and petioles of the epiglottis that were not involved by the tumor, but allowed me to get a full view of the underlying tumor and to gain, as you will see, an extra lateral spread of my surgical resection in order to have a safe margin both on the superficial and deep aspect of my resection and have a safe tumor removal. After right vocal fold resection, I vaporized some fat tissue in the upper paraglottic space, and then I resected also the left false vocal fold for the same reason, because I wanted to get an extra space in order to properly see and dominate the anterior third of the left true vocal fold. Again, this is a completely safe tissue, but it needs it's needed its removal just for getting a safer resection of the tumor itself. Then I also always remove the petioles of the epiglottis. This is for a couple of reasons. not just for having an extra infrapetiolar exposure maneuver as described by Zeitels and dominate the broil tendons from above in the points of its insertion to the thyroid cartilage, but also to be sure from the pathological point of view that the tumor does not reach this potential pathway of spread, which again is very difficult to be controlled in a subsequent recurrence or persistent lesion, because it invariably carries to a T3 or T4 laryngeal extension. So after supraglottic removal, I've got a full view of the tumor from above. And now, since the tumor is quite bulky and I would not be able to dominate its inferior extension towards the subglottis, I will proceed with the tumoral resection or piecemeal resection. My first cut is usually just in front of the orotracheal tube, and I cut the tumor from the surface to the vocal muscle, taking help from the different interaction of the laser beam with the cut tissue. As you see, when you cut the tumor, there is a lot of carbonization. By contrast, when you reach the underlying healthy tissue, you have got a different interaction. That means you have in the soft tissue. As you can see here, I'm cutting through healthy vocal muscle. This means that I'm lateral to the tumor, and I can safely cut into the cricothyroarytenoid space that, as I mentioned before in my previous lecture, is in my hands an absolute contraindication to TLM. So as far as I can see in this area, a normal interaction, laser soft tissue normal interaction, I mean no carbonization and safe tissue. So I go on with my resection and I take this extra soft tissue like muscular tissue, cartilage, and vocal ligament or posterior paraglottic space as an extra margins surrounding the tumor, and I'm happy with that. I'm exploring the cricothyroarytenoid space just to get an extra safe surgical margin. But if the tumor reaches the cricothyroarytenoid space, and I realize it at this point, for me, this is the stop of the TLM surgery, and I have to shift to an open partial laryngectomy, obviously after proper discussion with the patient, and I've usually done this before surgery if I'm in doubt that my TLM will be not radical enough. You can see here I'm cutting the arytenoid cartilage just in the junction between the vocal process, which is elastic, and the arytenoid body, which is hyaline cartilage. And then I cut through the vocal the remnant through the conus elasticus up to the cricoid cartilage, as you can see here, just to complete the posterior part of my resection, which is for sure the most cumbersome. Then I mark with the blue ink the safe margin of my resection, just to be sure that my pathologist will have a marking ink on what I consider the safe part of my resection. And then I will focus on the anterior part of my resection, which will include the anterior commissure and the anterior half of the vocal fold. At this part, I will reach for sure the thyroid cartilage, as you can see here, resecting the inner perichondrium just to be sure that I will leave a safe and healthy thyroid cartilage. On the midline, I will cut through the tumor again because the tumor was crossing the midline and was involving also the left vocal fold, as you have seen preoperatively. So I will cut through the tumor at this level and into the brow ligaments in order to resect the full anterior half of the vocal folds, the right vocal folds. Inferiorly, my resection will be carried through to the cricothyroid membrane. And then I will complete the resection with the last part of the tumor, which was the anterior half of the left vocal fold. At this level, the tumor was much more superficial. So as you will see, I will spare the vocal muscle and its insertion that you can appreciate now at the level of the thyroid cartilage. So I will just make a type 2 chordectomy on the left, seeking the plane in between the vocal ligament and the vocal muscle at this point, and then resecting just the very superficial layer of the vocal muscle, as always in the type 2 chordectomy, and then proceeding into the subglottis plane, detaching the third piece of my resection just in front of the vocal process of the left arytenoid cartilage that at this level was completely spared. So this was a left type 2 chordectomy associated with a type 5A and C chordectomy on the right. So an extended chordectomy. You will see at the end of the procedure, the resection is rather extended and seems also aggressive, but the only surgical alternative to this kind of procedure would have been a supracricoid partial laryngectomy, sparing both arytenoids and the epiglottis, so CHEP, which was definitely much more heavy for the postoperative outcome in this patient. Indeed, after this kind of resection, he regained oral feeding the days after surgery, and he was discharged 2 days after surgery. You see, there are no macroscopic doubts on persistence disease on both sides of the larynx. I tried to keep it at a minimum decarbonization in order to reduce the amount of granulation that, however, is always present after this kind of extended resection. As I will show you, however, 8 days after surgery, at our first postoperative follow-up in the office, this patient was badly dysphonic, obviously, but without any major complaints in terms of swallowing, pain, or function. There was a lot of fibrin and already some kind of granulation at the level of the right false vocal fold. However, you can see the sphincteric action and closure of the larynx is quite good. And this means that no swallowing problem was associated. And this was therefore a very good functional outcome. This patient, as you can see, was operated nearly 5 years ago and is free of disease at present. He didn't receive neck dissection nor postoperative radiation. It was just followed up by MRI and CT scan every 6 months for the first 2 years, and periodic and strict endoscopic follow-up in the first 2 years, and then with the decreasing incidence in the third, fourth, and fifth year, and now is free of cancer 5 years after resection. Thank you for your attention.
Thank you for the video demonstration. We have a couple of questions. Part of them you have already answered, but so one is, would you consider doing a TLM for a large volume T4 disease, or would you like to send it for total laryngectomy or an organ preservation protocol, if at all, if feasible?
Well, I do TLM for T4 laryngeal cancer only for debulking reasons, to avoid tracheostomy and to avoid asphyxia, obviously, in waiting for example, chemoradiation, radiation, or open partial laryngectomy or total laryngectomy. I consider TLM absolutely inadequate for T4 when you have got massive thyroid cartilage infiltration or extension of the tumor through the thyroid membrane or cricothyroid cartilage, or cricothyroid membrane. For me, these are not indication for TLM approach. Sometimes you can discuss about an open partial laryngectomy, because if just the thyroid cartilage is infiltrated, you can safely remove it completely by an open partial laryngectomy, and again have a free margin with the preservation of the organ. But in my mind, this is not safe by a TLM approach at all.
So what kind of, or what extent of resections usually result in aspiration or worsening functional outcomes?
Well, in my experience, I never had major aspiration after glottic resection, as far as I didn't remove the one arytenoid or caused an arytenoid fixation due to, for example, massive lateral extension involving the recurrent nerve. In that case, you may have some kind of aspiration. By contrast, when you deal with supraglottic resection or hypopharyngeal resection, then aspiration can be a problem in the first week after surgery, and most of time I put a nasogastric feeding tube in this patient because I fear massive aspiration after important supraglottic resections.
So in your experience, if the cricoarytenoid area is involved, what would be the surgery that you would prefer? Or what would be the extent of, if in your experience, the cricoarytenoid area is involved, would you go ahead with any sort of surgical extension to remove the lesion?
Sorry, can you repeat? I didn't take the question.
So if the cricoarytenoid area is involved, would you...
Well, no, the cricoid is in my hands removable just in its surface, mucosal surface. I mean, whenever I've got, for example, sometimes I go up to the trachea, but just for intraepithelial neoplasia or to get safe margin, extra safe margin of tumors that go subglottically. But when the tumor infiltrates the cricoid cartilage, or I've got doubts about this, again, TLM in my view is not a good indication, and I just switch to an open partial laryngectomy approach. In that case, by the way, supracricular laryngectomy is not enough, and I need to operate the patient by a supratracheal resection. I mean an open partial laryngectomy type 3 with the partial resection of the cricoid plate or cricoid arch. This can be done, obviously, in very compliant patient, healthy patient, young patient, or for example, some kind of non-squamous cell cancer like cricoid chondrosarcoma, adenocystic carcinoma, and so on, because they have got a different biological behavior, but again, they are very limited and very selected indication.
Also, you know, the general understanding and the reading for everybody has been that the early stage lesions have less access to lymphatic, especially the glottic ones. But the moment it becomes T2, T3, where it gains access to the paraglottic space or to the false cord or anywhere supraglottic, subglottis, the lymphatics are involved. So in that case, how is the neck addressed? I mean, do you look at doing them surgically, or do you treat it with RT, or you just observe them?
Cado. Yes, essentially, if you compare the two cases I showed you, the first one, if even though it seemed less problematic than the second one, indeed was at a higher risk of lymphatic spread, since the tumor was reaching the ventricle and the fourth vocal fold, and in that area, the lymphatic spread are very easy. And in fact, in that patient, instead of a 40-minute surgical procedure, I did an elective neck dissection 2 to 4 because I was fearing for lymph node metastasis. But even though the ultrasonography was negative and the postoperative specimen was also negative. In the second patient, instead, the tumor apparently was bulkier and larger, but it was purely a glottic tumor. I resected fully the fourth vocal fold, the ventricle, and so on, but just for having a good laryngeal exposure. And in fact, the ultrasonography was negative, and I decided to follow the patient just with the seriate echography of the neck, and in the following 5 years, I did not experience any recurrence in the neck. So I think that in the purely glottic tumor, even when you have got a relatively bulky T3 that you can manage by TLM, is safe to make just a wait and see policy with the seriate echography on the neck. By contrast, if you decide to open the neck to manage the tumor, for sure, at least in that case, at least 2 to 4 right neck dissection would have been for sure performed, just for a reason that you have to open the neck and you want to be sure that you don't leave neck disease beyond your procedure. Okay, do you hear me?
Any experience with chondronecrosis?
Well, chondronecrosis was experienced in my life just after extended resection like this, after failure of radiation, or when at the beginning of 2000s, we tried to reduce the amount of granulation tissue by using mitomycin C. And in fact, we stopped the use of this drug after having a couple of chondronecrosis after type 4 or 5 chordectomy, in which we put the mitomycin on the bare thyroid cartilage. This caused a very slow healing process, and we got an infection, chondritis, and chondronecrosis. But apart from these cases, I would say that chondronecrosis is very rare if you follow up if you give antibiotic therapy to your patients when you expose the target cartilage, and if you follow up them properly, and in case of suspicious infection in the larynx, deliver an aggressive antibiotic therapy, or electively or therapeutically.
Cesare, I need to ask you, what about preservation of the what about preservation of the false cord? If you preserve the false cord, in your experience, is the voice somewhat better in rehabilitation?
Yeah, it's definitely the case. And in fact, whenever I can do it, I do it. But the situation must be very clear. I mean, without resecting the false vocal cord. Whenever I feel that I cannot dominate completely the lateral extension of the tumor at the level of the glottic plane, then I do not hesitate to fully resect the false vocal fold. For sure, when you're able to preserve it, you will have a fantastic voice. Most of the time, there is the formation of a laryngosele inside the false vocal fold that recreate a sort of new hemilarynx against which the most resected part, for example, the scar tissue, can vibrate and close the glottic gap in a very good way. So when you're able to do that, you will always have a very good voice outcome. But the point is that do not sacrifice the oncological radicality or the oncological safe margin to get a better voice. This is my point.
Agreed. Excellent. Thank you.
Thank you, Bart.
Thank you. Thank you. So now we would be having the concluding remarks from the speakers.
Good.
Hello, Carsten, I think you can start with the...
All right. Look, I think this was this is just great. You know, actually, again, as I've said before, you guys should really be congratulated for the initiative that you've shown to provide education in this unfortunate world situation where we can't attend regular meetings. I think this is a wonderful platform, and I personally get a lot out of this, and I hope everybody has found this very, very interesting. I think, you know, it's great to have our colleagues from Italy who have got such phenomenal experience in transoral laser surgery, sharing their wonderful knowledge and being so generous. So I really want to congratulate them and thank them very, very much for attending. So Akshay, well done, and let's keep going. Thank you.
Right. Thank you. Professor Farouk?
Yeah, hi Akshay, Anand, thank you all for organizing it. I think it's fantastic. I think I've learned a lot, you know, starting from the very basics of how to work out what lesions are all the way to what Cesare showed is just incredible. You know, certainly we don't go to the same extent, but I think it's good to see what can be achieved. Yeah, no, great platform and great exchange of ideas. I think Tata Group and Alok and everyone, it's nice to see familiar faces again, and nice to see what you have evolved into in 5 years. Fantastic. Since you left us, it's been 5 years.
Yeah. Thanks. Thank you. Farouk, for the and Carsten. Professor Piazza, it was a treat to watch your surgery on that extended resection. So yeah, your final comments. Unfortunately, we won't have you for the next meeting. Yeah.
Oh, thanks a lot. Do you hear me?
Yes.
Yeah, sorry. On the 5th of July, I will be on holiday after 6 months of COVID issue. so it will be a long demanded holidays. But I really congratulate your work is excellent, and I'm honored to be part of this work. Thank you very much for.
Thanks a lot. It's a pleasure. Actually, in fact, I was supposed to visit Italy before this COVID on the Feb 28th, and then I dropped my plan. But yeah, this meeting really kind of enlightened us for the whole of about laser surgery. Thanks again, Dr. Francisco.
Thank you for this invitation, and thank you, Akshay, to have organized this wonderful meeting. I think it was very helpful, and also nice to see also the agreement with our policy of excisional biopsy also in your country and so on. And I will be here also next Sunday, of course.
Yeah, thanks, Francisco, for connecting me with Dr. Piazza and, of course, Professor Peretti. Paiser, your final comments.
Yeah, I should thank Akshay for this wonderful education talk that you arranged, and he has arranged this for the past 2 months. I'm amazed at his strength and tenacity to do this. It takes a lot of effort to organize this and get the world leaders on a panel for educating the youngsters. I think it is time that the surgeons have to take the mantle and treat the laryngeal cancers and not push them towards organ preservation. And as Professor Cesare and Francisco showed, and as Farooq and Carlson are here, I think it is time for the youngsters to take up this role of transoral laser surgery. For long, it has been a requirement, and I think now is the time that, especially in where patients cannot afford long treatments, a single day surgery like Cesare showed, the patient is cured. So I think it is a very good opportunity that you have created here. And I should thank the Academy of the Head and Neck Surgeons of Karnataka for organizing this. Thank you very much.
Hey, sir, you're always an inspiration for youngsters like us. Finally, I thank my mentors, Professor Palm and Professor Rifat, who kind of refined me in my skills in transoral laser surgery. But I think there are a lot to learn. I'm definitely wanting to visit Professor Peretti's unit and Piazza's unit next time, probably after a year or so. So all these has been possible only because of the effort of the team. So Anand had done a wonderful moderation today. Thanks, Anand, for the wonderful moderation.
Thank you.
Bhargav is there always on the back seat. He's a technical guy. He runs the Zoom meeting for us. Bhargav, thank you very much. It was a very smoothly conducted meeting. Thank you, Bhargav.
Yes, sir.
And of course, Shalini Thakur, my colleague, she's there all the time for any kind of support, and she was actively involved. Thank you, Shalini. And I'd like to thank my fellows, Dr. Joshna, Dr. Apurva, Dr. Abhijit, Yash, my senior colleagues. Without whom support, this is not, it wouldn't have been possible at all. Professor Vishal Rao is always encouraging, is always there to help troubleshoot problems. Professor Ravi Nair for his advices. And of course, our chairman, Ajay Kumar, who always want us to do these kind of academic activities. Thank you all participants for joining in. We had a little bit of a less participation, but probably we'll have, with this kind of a discussion, I'm sure the next meeting, we are definitely going to have more participation. It was really good learning, lot of information, lot of opportunities for collaborating with each other. Thanks. Thank you, everyone.
Thank you.
Bye.
Bye. See you again. Bye-bye.
Bye-bye.
Ciao.